background. Now it's okay. Dear friends, respected colleagues, ladies and gentlemen, good day for everyone who follow us in this moment. It's my measureless pleasure to open the Jubilee 10th USSI EDI Congress. This time it is in form like webinar, but I promise the next year will be face-to-face. There are many reasons for that. First of all, I would like to thanks to my organized committee and principal secretariat for the health who support me and help me to organize everything. The greatest gratitude, certainly it goes to you, lecturers, excellent experts, wonderful friends, who helped me to organize this meeting with your active participations. Many thanks to you, Christian, like our president of BDI EDI. This year it's almost 20 years of our good cooperation and our friendships. At the last, many thanks to President of EDI UK, Dr. Eamar O'Connell from Scotland, from UK. Many thanks to Professor Dr. Peter Faber from London, from England. Today we will see, and tomorrow, our excellent lecturers from Great Britain. The next is Professor Dr. Thomas Fortin from Lyon, from France. Then Professor Giulio Rasperini from Milano, from Italy. Professor Dr. Hakan Özzivaci from Istanbul, from Turkey. Then Dr. Vikas Gold from Banyara Hills, from India. Dr. David Alfayed from Porto, from Portugal. Assistant Professor Dr. Kirill Polyakov from Montenegro. Assistant Professor Dr. Nikola Petricevic from Zagreb, Croatia. And at last, our Serbian guys, Assistant Professor Bojan Jovicic from Belgrade, Professor Dr. Stevo Matijevic from Belgrade too, and our Professor Siniša Mirković from Novi Sad, from Serbia. Leave me and to say one words about our friends, sponsors who help us a lot. That's first the golden sponsor Miko Dental Depot, then Iris Factory in Implant Factory, then Natura Lab, Curaprox, Dentigol Dental, RTG Center Miletićeva, Technodent, and that's all. Thanks again for all, and I declare to the 10th Jubilee USSI Congress, it's open. Thank you again. Sorry, Christian, because I'm a little late. And I would like to see you first, like many years. You know, today is our 10th Jubilee Congress. Thank you again. And so many thanks. You are very great, our supporter and great friend from Germany. Good day again. Christian, it's word is you.
Thank you very much, Soran. Can you see the pictures that I'm projecting?
No, we see you, but know your presentation. But for yes, now we will see the first slide.
Okay,
Yes,
perfect.
Christian. Yes, please start, Christian, and good luck.
Soran, thank you very much for the invitation. If we talk today about consensus recommendations, then first we have to state that implantology is a very successful and a very secure procedure in dentistry. So if we have recommendations for the dentists today, it is more about avoiding mistakes than to bring a new step forward in implantology. Let me show you. A poor prosthetic treatment planning and/or a poor execution of implantology may lead to malpositioning of implants. This could be unintended, or it could be just because you use the wrong strategy. I will show you some examples of this. Can you imagine how to restore these implants? They are clearly out of the maxillary reach, and it's certainly unintended. Nobody would be so foolish to plan a thing just like this. Let me show you another example. If you have a lot of bone, why would you use an implant with a very short body? So this implant is even shorter than the neighboring teeth. And of course, if you have an inflammation, just like in this case, it's very difficult to solve the procedure and not to lose the implant. Now we come to unintended or by wrong strategy. If you have enough space and if you place implants in the maxillary on the left side with a lot of inflammation, then you should care of the inflammation. So you should care of the inflammation before you think about placing a new implant. Because even if the local bone around this missing tooth, 1, 2 is perfect and enough, you should take care of the 3 implants in the upper left maxillary arch before you place an implant in the front. So don't use a wrong strategy. Here again, you see an example. You have unerupted teeth in the maxilla and in the mandible, and an implant was placed just in the middle of the mandible in the lower arch, where an implant would not be necessary if you could do another treatment option. And then again, you have a wrong strategy. If you look at these implants, you can hardly imagine that a tooth which has 3 roots, like an upper molar, is restored by 3 implants using the 3 alveolars of the 3 roots. But it happens. And it's even published. 44 roots, 44 implants. In this journal, it's even written as a scientific article. So here you see how these many implants are placed in the maxilla and in the mandible. And they are restored just like this. So always think about, what do you really want to have? I think you will have success if you avoid any failures. You can do it on an evidence basis versus just accidentally placing implants all around the mouth. You should distinguish between a complication, an inflammation at an implant which you placed many years before, against maltreatment. All these implants which I showed you up to now were maltreatment. And you have to plan your things instead of just going on doing it on the patient. And then you get predictability versus risk management. Here you can see a bicycle accident of this young lady. She got cured in a hospital here in Munich, but one of her teeth did not survive this bicycle accident. And even though the surface of the wound is healing very much, she still has the problem in her mouth. And here you can see one tooth is missing, one tooth was a little bit altered. We made a little filling on this tooth 2-1 just for a provisional treatment, because we were not sure whether you would have to do endodontics on this teeth or not. Then you can see on this image as well that if you are doing an implant procedure, then you will lose tissue. This lady had missing a teeth, but the papilla distally of tooth 1 to 1 and mesially of tooth 2-3 were still there. But if you look at the picture down right on this side, then you see a suture, a dark suture, and you see the papillas are already missing a little bit. Don't worry about it. You can rebuild these papillas. And I will just show you this. So here in the upper two pictures, I show you the papillas and the missing papillas. And then you see the restoration, the crown on tooth 2-1, and you see the implant on tooth 2-2. So you can get a perfect restoration if you just follow the guidelines. Following the guidelines means that you have to look at the patient in total. You should not only look at the side where the tooth is missing, but you should also make a comparison. So you can see it on the upper two pictures, but also if you look at the lateral side, here you have tooth 1-2, and you have to compare it with the implant on 2-2. And here again, you see how it blends. And this picture was taken 10 years after implantation. So you can solve the wound on the other side, on the outer skin, as well as inside the mouth. And if we are talking about predictability of success, then you have to have good primary conditions. And you, the dentist, you can do a lot for getting these primary conditions. In this case, we had a young and healthy patient. By the way, she's a doctor for anesthesia, so she knows how to treat her teeth. You have to do a correct planning and treatment. A single implant between teeth seems to be difficult, but it's easier than to place implants in places where no implants are and where no teeth are any longer. And you have a strict aftercare. As I told you, she was a medical student at that time, so she did undergo a strict aftercare, which is very important if you are looking for a long-term success. Let me come to these guidelines I was talking about. If you look at the top, then you see the guideline of this spring was an update Cologne ABC Risiko score for implant treatment. Last year was an update on ceramics. We had an update on peri-implantitis, and having updates tells you that we already had guidelines years before just about these things. And if you look at the guidelines from 2014, it's second from the bottom, it was avoiding implant malposition. And you can download all these guidelines on our website, so it shouldn't be a problem for you to get all this information. And if we are talking for criteria for long-time success, then we have to think about what should we do, when do we do it, and why do we do it? Because keeping the tooth has a lot of possibilities. You can do endodontic treatment, periodontic treatment, endodontic revisions, root resections, surgical crown lengthening, and post and core procedures, or you could place an implant. So you always have alternatives. If you are talking about keeping the tooth, then you have to ask yourself, is it a periodontal problem or is it an endodontic problem? How can we treat this lesion, and will the treatment, whether it's periodontics or endodontics, be successful? And one of the questions is as well, are teeth more reliable than implants? Look at this case, a female patient, 48 years old. The dentist refers to my office because of a fistula between tooth 2.5 and 2.6. You can see it on this little yellow arrow. Tooth 2.5 is clearly not sensitive, and the teeth 2.4 and 2.6 are clearly sensitive. So the diagnosis is easy. You should do an endo on tooth 2.5, give it some medication, but the fistula does not heal. So why doesn't it heal? We can see at the x-rays there is not very much to see about these x-rays. Here you see the endodontic approach of this tooth. Again, the bone around the root of this tooth 2.5 seems not to be alterated, but we cannot heal it. It comes again, and it looks just the same as it was before, even though the radiographic aspects of this tooth were quite good. So we have to think about it. Why does the fistula not heal? Is there a root fracture? Is there a second root canal? Or is another tooth responsible for this picture? And is a CT scan more helpful for a further diagnosis? Yes, it is. If you look at the CT scan in a three-dimensional way, then you can see around this tip of the root, you can see a lot of free space inside the bone, which was not so easy to detect on our first X-rays. If you look at it from another angle, you see there is a lot looking like a cyst inside of this bone, and it goes to the interior of the body. It's not a swelling going outside, but it also goes inside in direction of the sinus maxillaris. So now we know what we have to do, and you see on a CT scan, it's easier to detect these lesions. A root resection was performed, so we open up a flap from the outside, look at this tooth, remove it, take out this inflamed material. And if we do so, we can later on close the whole flap, seeing it very clean. We suture it, and it will be healing. And I hope you can imagine that this patient was very happy of not getting revision again. So you see the resected root on the X-ray down on the right-hand side. And in this way, we could heal this patient. So my take-home message for you about teeth is the predictability for long-time success. Solve endodontic problems, just like I showed you. Heal periodontic problems and prevent prosthodontic problems. I've talked about this guideline of 2022, which was released in April. And you see an international board, and with these participants, a lot of the people which are presenting to you today are on this group, and it was a very successful meeting. So thank for all these people who participated. If we are talking about risk management, then we have to ask ourselves, was it the right patient for us? And there is a simple system, ABC risk score, which helps you in the 3 colors of the traffic light to give you a better opportunity to rate the planned implant treatment. Each of the patients in this risk score gets 4 scores. The medical history of the patient, the surgical score of the patient, the local findings around the place where we want to put the implant, and the restorative score. So let's start with the risk management. Green, yellow, and orange are corresponding to A, B, and C, or always, between, and complex. This means if everything is green, it's an always case. Any one of us could do it. If we have yellow components mixed in this, then it's already between an always case and a complex case. And if we have orange components, then it's already a complex case. And you should always determine whether you are able to solve a complex case by yourself or whether you have to ask another colleague to help you. So you can see also these colors as low risks, then it's green. In between, then it's a medium risk, and a complex case means an increased risk. Again, if all four components, the medical history, the local findings, the surgical situation, and the restorative solution are green, then every dentist is able to do it. If it's green and yellow, it's already an in-between case. If everything is yellow or one of the components is orange, then it's a complex case which you should look at. Maybe you can bring it with some treatment options to a better score. Red is reserved for cases where the risk management showed that treatment should not be recommended now. It does not mean it's contraindicated, but if you look at the yellow sign on this screen, then you see that a periodontal disease is just like an irradiated jaw or a diabetes mellitus, something which brings us in trouble. And if you have an untreated periodontal disease, then it's almost as risky as after irradiation of the jaw. And you would be very aware of irradiated jaws. So please be very aware about untreated periodontal disease. Here you see a picture of a young patient. She's 20 years old, she's not smoking, so she cannot have periodontitis. She's a very always case, so lowest assessed risk. She has a traumatic loss of a tooth at the age of 11, which was restored by a Maryland bridge, which we see in the central photograph. And now she comes for wisdom tooth removal, and she wants an implant now because she now is 20 years old. So if we look at the orthopantomogram, we see the Maryland bridge and we see 4 wisdom teeth. And our treatment plan is to augment the region of the missing tooth 1-1 to do an implantation. We should give her a provisional crown, and then after this, a final restoration. Our first step was to open up the site where we need bone, and you see that there is a bone loss just because she did not have a tooth there for 9 years after losing this tooth 1-1, and we have to augment this site. So while taking out the wisdom tooth in the mandible on the right side, we used this bone to do an augmentation where the bone was missing, and you see 3 little metal pins that hold this retromolar bone block now at his new site. Here you can see the 3 little screws you saw already on the X-ray. And you see, if you do such a bone block and fixate such a bone block, you should always overextend. So you have to do an augmentation of more bone than you will be needing, because you will be losing a little bit of this bone. You can cover the side and you let it heal. And after a time, you can take out the 3 little screws and make a soft tissue management, so that after healing of everything, when you want to place the implant, you have already sufficient buccal bone for an implantation. Now you can place the implant. You can again do a little bit of augmentation. In this case, it's not necessary to use a membrane or something like that, because you would limit the healing possibilities with the membrane. So just leave it like it is if you have a periosteum to cover it. And then you let it heal, and you can also see that the implant is a little bit underneath the surface to get a good surrounding bone around the implant. You cover the side and you see the implant, and you, as you imagined, I used the existing Maryland bridge again as a provisional bridge to heal this side, because this Maryland bridge you can trim just like you want it. The patient is already used to this Maryland bridge, so why not use it again? After some months, then it's time for the second intervention. And I want to show you these photos to make it clear to you that you wish to have white tissue around the implant when you are putting in the abutment. So you have to give pressure on the tissues. The pressure you give to the tissues helps you to get papilla between the tooth and the implant. Here you can see it. In this situation, there is already the abutment inside of the implant. This is the final abutment where we will place the crown. In this case, it was a ceramic abutment. But what's important, that you have now a healthy tissue around the implant, which is similar to a papilla. It's not a papilla because a papilla is by definition between two teeth. Here you have a tissue between an implant and a tooth, but it looks like a papilla. And now you can see it really looks like a papilla. And with our augmentation, we already brought the gum tissues to a situation where you have the imagination that this missing tooth could be a natural tooth. And you see that this situation stays stable, in this case, for more than 8 years. Here is a young lady, and the implant is restoring the missing tooth. So let's not only talk about my recommendations or the recommendations of the group which was together in April 22. We have a consensus statement already from the year 2013 for prevention and management of biological and technical implant complications. They did bring together a lot of knowledge and a lot of literature. And the summary is that the long-term implant survival and success rates are lower in patients with a history of periodontal disease adhering to supportive periodontal therapy compared with those without a history of periodontal disease. So always keep in mind that a periodontal disease is almost as dangerous as a diabetes mellitus, or if it's not treated, this periodontal disease, it's almost as difficult as having irradiated bone in front of you. The findings of this systematic review indicate that pre-existing peri-implant mucositis in conjunction with lack of adherence to supportive periodontal therapy was associated with a higher incidence of peri-implantitis. So always first treat the periodontal disease, then in a second step, place the implants. The residual periodontal pockets are a risk for peri-implant disease and implant loss. Therefore, completion of active periodontal therapy aiming for elimination of residual pockets with bleeding on probing should precede implant placement in periodontally compromised patients. And in cases of residual probing depths more than 5 millimeters with concomitant bleeding on proben and full mouth plaque scores more than 20% are associated with risk factors. Retreatment and periodontal re-evaluation are recommended before implant placements. So just do a periodontal score before you place your implants, and as long as this patient has pockets with more than 5 millimeters of probing depth, just take care of this periodontal disease and heal it, and don't place your implant before you place the don't place your implant before you heal this periodontal disease. The treatment guidelines of this group are, as peri-implantitis is an infection associated with the presence of submucosal bacterial biofilm around implants, the primary goal of therapy must be the resolution of the infection, which is achieved by the disruption of the biofilm, the removal of calculus and/or overhanging restoration margin, and the prevention of recurrence of the disease. The following sequence of treatment of peri-implantitis is normally recommended. Pre-treatment phase including thorough assessment and diagnosis, reduction of risk factors for peri-implantitis, because in poor oral hygiene, prosthesis that prevent adequate access for plaque control, tobacco use, presence of periodontal disease, and systemic diseases may predispose to peri-implant disease. If required, remove the prosthesis and do an adjustment or replacement. Non-surgical debridement focused on maximal removal of biofilm is necessary with or without antibiotics, and an early reassessment of peri-implant health comes normally within 1 or 2 months, and then you can place your implants. Surgical access if resolution of peri-implantitis has not been achieved. This should include a full thickness mucoperiosteal flap and removal of granulation tissue to allow thorough cleaning of the implant surface, thorough surface decontamination of the implant and the restorative components. And the following techniques have been proposed: locally applied chemicals, gauze soaked with saline or antiseptics, hand-powered instrument, air-powered abrasives, erbium YAG lasers, photodynamic therapy, and implant modification. But please note, there is no evidence for the superiority of any of these approaches. So it means you really have to clean the surface, no matter how, but clean it. Let's look at this young male student. Almost like the young lady you've seen. Also a trauma on tooth 1-1. The dentist did endodontics. They did root resections, but it always was with swelling and pain. So then at least the tooth was extracted and there was done a socket preservation with bio-os and connective tissue graft. Good procedures, no doubt about it. But if you look at the side now, then you see you have a swelling, you have a bleeding in this side. It's a every sign of infection is here. So let's look at this side. You see it in February 2012, and you see it in October 2012. What happened? If you look at the X-rays, then you can see that even in June and in September, there was bone just coming back from to where it belongs. And again, we look at the CT scan. And on the CT scan, you can see that after root resections, of course, there was a buccal opening of the bone. After tooth extraction, of course, there was something not going well in the treatment of this alveolar. You remember there was bio-os filling up the gap, and there was connective tissue grafting to cover up the whole site. So you have to ask yourself, how could this infection develop? How would you fill the defect which is now there? How would you treat the site, with an implant or with a bridge? For this young patient, a bridge is also not a perfect solution. And how long would you wait before you place an implant? Let me show you. On the bottom, you see the CT scan. But always keep in mind that even if you don't have a CT scan, you can always check a site before you place an implant. You just give anesthesia to the patient, you take a needle with an endodontic stop, and you can just try to find out how much bone is at the site where I want to place the implants. In former days, we did not have CT scan, so we used casting models, and we really marked on the model where is the bone, where should be the implant, what should be the direction of the implant. Nowadays, thank God, we have these CT scans which make it much easier for implant planning. But you are not relied to a CT scan as the single solution. You can always go on in deeper diagnostics. So here is this site. It was filled up with bone, again with bone chips and with artificial bone like bioas. The site was covered. The healing was going on for 6 months. So you see that even after taking out the wrong material to clean it, it did heal from February 2012 until November 2012. Then it was time to place an implant. Of course, again, we had to do a connective tissue graft to augment the gums a little bit. And you can see on the photographs that the wound from taking out the connective tissue graft will certainly be a little problem for this young boy. But we had to take out such a tissue to bring it up to the front to have enough soft tissue for the implant success. So if you look at it now, then you can see we have enough space and we have enough material to place an implant at the right side. We have some tissue around the implant when we are doing the abutment placement, and we bring pressure again to the tissue to make it look whitish. So the blood is a little bit compressed, the tissue is compressed to give it a perfect healing. In this case, just try to make as one suture or maybe 2 sutures, but the less sutures you are needing, the better the tissue will heal. So again, you see a gum tissue around the implant, which looks like if it would be a papilla. It looks healthy, and you can put on a provisional crown to get the whole site healed. And again, it takes a few months until you can finally make a final crown on this missing tooth or on this implant. Then after placing the final crown, you can compare between the implant and the neighboring tooth. And you can go to a quite stable solution. You see, we started in February 2012, and now we are in 2022, and it still looks like it was after the placing of the crown in 2013. Here again is this young boy, and you should not only see the teeth, you should also see the whole guy, and it looks like a nice result. So let me finish with a combined case. which means we have prosthetic treatment planning, we have implant surgery, and we have a prosthetic-driven restoration. This man was 65 years old. You see, he lost a lot of teeth. Most of his teeth in the mandibular are loose, he already lost, but also in the maxilla and the crowns and the bridges are not very nice looking. I myself made a mistake. I lost buccal lamella during tooth extraction. So always try to do your teeth extraction as carefully as you can. In this case, we just solved it with a little augmentation, which I will show you on the next slide. So you can see the situation after extraction. And when we placed an implant, you can see in the at the yellow arrow that we augmented around the implant just on the side where this buccal lamella was going away during tooth extraction. I just want to show you the total case. So we could save some of the teeth. We placed some implant and now we have to bring all this together and to give him a nice outcome. You see the few steps. First, you see the old bridge work in the maxilla. Then you see the implants at stage 2 surgery. And then you see the maxilla after healing with provisional crowns and bridges. Again, you see the implants now with the ceramic abutments inside. And then again, we placed a prosthetic intermediate solution. So these crowns are not ceramic crowns, but are crowns made of plaster, just to have some intermediate treatment. And then you see the ceramic crown in this patient. You have a before and after. So we had to lift the whole situation a little bit. The distance between maxilla and mandible was augmented, and we gave him back a normal smile. You can see it on the X-rays. 4 implants in the maxilla and 5 implants in the mandible, with restoring the still existing teeth. We did it, or I did it, in small units. So do not make a whole arch. Always try to make little solutions for little areas. In this case, you are able to restore and to help the patient if something is going not so well during the following years. And my take-home messages for implants for you are, for the predictability for long-term success, good pre-existing conditions, and always keep in mind that you are responsible to create these pre-existing conditions. Pre-existing conditions are never good or perfect, because if that would be the case, then the patient would not be in your chair. But you have to create good pre-existing conditions by periodontal treatment, for example, by endodontic treatment. Do a correct planning and treatment, and keep the patient in a strict aftercare, so you can see little small inflammations which you can always handle, and you are not going or running into big inflammations which are going out of your hands. So if you are asking me about consensus recommendations, what, when, and why, I just tried to show you some examples, and thank you very much for your kind attention.
Thank you, Christian, for thorough and fundamental lecture. We expected this lecture from you, I like your lectures because our questions, maybe you see on the monitor, have some connection with this. And I would like to know, are that recommendation from European Consensus Conference more important for private practitioner, for private practice, or for some control organ like inspection in countries of European Union?
Yes, Oran, we do not give this to any control organs. These are recommendations from colleagues to colleagues, and we just want to help our colleagues. We are not giving it to anybody else. And if anybody else, if any control organ would get these recommendations, you can see these recommendations on the internet, then they cannot do much with these recommendations. They can just say, yes, it's right what this group is saying, not more. So it's not controlling the dentist. You always are free to do whatever you want. And if you are so crazy to have a patient with severe periodontal disease and you are so crazy to place an implant, it's your obligation. So recommendations just show you how to do it. But you are always the driver in the car.
Yes, thank you. And the second question is similar like first. Are that recommendation implemented in some officially form dedicated to private practice in general?
Well, you can always have these recommendations from the internet. You can print it in your office. You can even give it to the patient to show that you are following in your treatment these recommendations. And of course, if you are going to the third questions, these are recommendations for all countries. We have, as you know, people from India in our group. So the periodontal disease in India is not different from Serbia or Germany. It's just periodontal disease, and we have to treat it in every country. And the recommendations are the same for all of our countries.
Okay, thank you very much. And the third question?
That's just what I wanted to answer to you.
Yeah, yes, you answered just.
Yeah, I wanted to keep it simple for the day. That's why I showed you that even if you do not have a CT scan because you are working, I don't know where, in the middle of nowhere, then you always can keep in mind that you are able to find out how many bone is at the side where I want to place the implant. If you can do it with a CT scan, that's perfect. But if you don't have CT scans, then you just have to do it like our fathers or grandfathers were determining where to place the implant.
Nice. Thank you so much. And can you see the pictures behind me?
Yes, of course, you are already on Carnival again.
Can you remember? And this is from first.
Yes, I know it's in Novi Sad on top of the fortress.
Yeah. And I'm sure you recognize our friend, which is not with us, our Bernie Bros.
Yeah.
Yeah, I find a lot of pictures. And can you remember at the last 15 years almost?
Of course I do. And you, let me say at this moment, you are doing a great job bringing these people together, bringing these people to Novi Sad. And I know it was not easy for you during the last 2 years with the pandemic, but I hope now everything is recovering, at least here in Germany. We are recovering, and I hope to see you and the other friends very soon.
Yes, I hope and I promise the next meeting will be normally face-to-face, but a lot of problems with organization, and a lot of lecturers suggest me that is this way on to the webinar is the better solution. And for this year, it's this way, but the next we hope to see normally. The past the time passed very quickly.
Yeah.
And the 10th Congress, it's very imposant, the number of the years of
Right.
our operation, and I wish you good health for your family and your close friends, and tomorrow for your assembly of your Bavarian Dental Chamber.
Yeah.
I know you are very busy, and thank you again for your time, but please, more few seconds, recognize the Axel from Köln, and our friend, docent Dr. Voislav, our friend Voislav want to say a few words, and I leave now. And thanks again, Christian, and bye bye. Auf Wiedersehen.
Thank you very much, and bye bye.
Good morning, Christian.
Good morning.
Thank you for this excellent lecture. It was really good. Problem is, as you said, generally medicine is never 2 and 2 and 4, always. Sometimes 3, sometimes 4. But some midline have to have it and then struggle with some other problems. Generally, our business job profession is to solve the problems.
Right.
Always in problem, right? So I think it's excellent that we have some large group of professionals recommended help it or somehow make some committee to do it, to help the younger and more less experienced class. So I think it's excellent. Of course, it's excellent.
Yeah.
Mostly is not 2 and 2. By my impression, is generally like that. So thank you very much. Really, there's nothing to ask. Generally, it's obvious, very good presented. So it's nice. It's very nice. Thank you. Thank you very much.
Bye.
So there is no, I can see no questions. You have the same. There are no. For the discussion, there is no questions like this. For example, I will use some this time for, as I wait for somebody to ask question. I had a case with a young boy, underage, he was 17, in our country is 18, right? Had a lateral incisive in the nose.
Mm-hmm.
He was stuck inside, and grown up to the nose. That was not realized by the colleagues. They destroy it, make a horrible thing, try to move it, and something else. He was actually stuck inside. And everything I done was against this proposition, but only way I can do it. And it is just because I'm experienced more. All the doctors have some more experience. So this is the point, that's something that you have to have general guideline, for example, to think of, and then solve the problems, how it looks like, how it came.
Right.
Because if you see that when I take it out, I took a piezo knife, everything, to do it less, but there was no bone, nothing. I do artificial bone around, so there was only place, and it was more palatino because there was no position. So this is everything generally is wrong for the statics, but in this case it was impossible. So generally it's very, very important to have some midline in generally advising, did by the experience, a lot of doctors who are elderly, a lot of experience, and it happens, of course.
Right, and I think our patients do not expect that we always take a gun and shoot from the hip. So sometimes it's just better to step back one step, tell the patient, come back next week. I will keep up my mind. I will read some books about it. You don't tell him that you have to read books, but in this time you can go back. You can look at these consensus recommendations. You can look at some other or think about some other dentists and just talk from colleague to colleague, from friend to friend. What would be your solution for this case? I think that's just what we have to do. We always have to think about ourselves and not to be too quick. We have to give the solution to our patient. He asks for the solution, but he doesn't tell you, doctor, tell it now or I will never show up at your office. He just will give you the time for a good solution. And the more time you spend in the beginning, the less time you will have to clean up your mistakes.
Yeah, yes, of course. So
I've tried to make it simple for the people. You can find all these consensus recommendations on our internet site, but I gave you my email address. So if anybody has a question after today, and if I can be of any help, just let me know and I will answer these questions whenever it's necessary.
thank you, sir. Thank you very much. I'm sorry, there is a time to call Scottish colleagues, so we have to finish this. Unfortunately, it was excellent, really excellent.
Thank you very much and see you soon. Bye-bye.
Bye-bye.
This flesh and bone is just the way that you were tied in. Now there's no one home. I agree. For you, it's so hard to move on. Still loving what's gone. They say life carries on. Carries on and on and on and on.
Hello, colleagues. I'm calling Dr. Emma O'Connell from Scotland. Her lecture is Digital Tools for Implant Dentistry. So I'm calling her, and we have to wait maybe a couple of minutes that she connect us. Thank you.
I can't handle this. I'd read for you. And you let it out and move on. Missing what's gone. They say life carries on. They say life carries on and on and on.
Hello, I'm here tonight to talk to you about digital dentistry and to share with you some of my experiences in general practice. I live and work in Scotland, and I'm just going to share my screen with you so that you can see my video and presentation. Thank you. So my name is Emer O'Connell. I'm originally from Ireland, but I live and have worked in the UK and in Edinburgh for 30 years. I've owned my practice for most of that time, and my practice has developed as a result of investing in digital dentistry. And I'm going to share with you some of my thoughts about why this can improve your practice. This is just a little tour of my practice. For those of you who don't know, Edinburgh is the capital city of Scotland, which is one of the 4 countries in the United Kingdom. We've just had it renovated at the end of COVID, and this was the end result of that renovation. So really what I'm here to talk to you about is, does the use of digital technology simplify implant dentistry? I hope that I will be able to show you that it does simplify it. But of course, by saying that something is simple does not necessarily mean that it is easy. For example, when we get up in the morning and we decide we're going to go for a run, that's a pretty simple thing to be able to achieve. However, it's not very easy. And especially if you get up and it's raining, you open the curtains, it's cold outside, it's wet. The resistance to change and the resistance to do that simple thing like go for a run is very hard to overcome. So to change is difficult, and going digital is a change, and it does require some energy and investment. It requires both investment of time, of money, obviously, in the products, and then you have to invest a lot of energy in just getting au fait with how to use these tools, because they're slightly different from using the old-fashioned impression techniques, etc. But one of the keys to success, I think, is getting your team involved in this. And really, why would you bother using digital dentistry? Well, no patient wants to sit in the chair for 5 minutes more than they have to. So if it can be done with as high quality, but in a more efficient manner, then why would you not? It increases your profitability simply because it does use the chair time more quickly. It also engages very greatly with your team members, and that can help to with staff retention. I think post-COVID, a lot of dental nurses, especially here in the UK, have left the team, and we've had 3,000 drop off the register this year alone. So that means that recruiting and retaining staff becomes more important, and I think digital dentistry has helped me to keep my staff engaged and help them to get involved in the patient care. And if you look at some examples in history of things that people that didn't change, you can look at Kodak. Back in 2008, they were worth 30 billion, but they were bankrupted by 2013 because they decided that they didn't want to change. They believed that the film would still be the main mode of capture of photography, but in fact, they were wrong. They gambled on the wrong horse. The same with blockbusters. They didn't believe that digital streaming would ever change how their business model was running, and they kept investing in DVDs and the rental market. But of course, that we know from Netflix and Amazon Prime, etc., that things have changed beyond belief. We can always look at American consumer behavior, and that is usually a predictor of what can happen, especially here in the UK, but in other parts of Europe. And it is happening whether we like it or not. And I was at the CEREC conference in Vegas a couple of years ago, and one set of practices along the west coast of America had fitted their 1,000,000th CEREC restoration. So I think that gives you some idea of the power of the digital. One thing that often strikes me is that when I first started in my journey in dentistry, it was very much about people needing treatment. So we would say, you need a root canal, you need a crown, you need this, you need that. But digital dentistry helps people to see things that they might want. So for example, old metal fillings being replaced with composite or porcelain inlays or onlays. When they see that in 3D and they see what that looks like, it becomes that they want to have that treatment done rather than that they need to have it done. As I'm not being paid by anybody tonight to talk about any scanners, I'm going to talk about all of the scanners. The scanners that are available, this is just some of them at the moment, but there's Itero, PlanMeka, PrimeScan, Trios, Carestream, Lava, and 3Shape. The thing that you must look at when you are thinking about investing, especially making this capital purchases, you need to look at a thing called metrology, which is basically the science of measuring. And we look at whether something is accurate and precise and whether it can reproduce a true representation of the actual object that it's scanning. And we know that conventional and digital impressions are now accurate to 50 to 70 microns. And in fact, we now know that with some of the scanners, they have even superseded what we can do with conventional impressions. And because there's less stages in it, you can go straight to the lab and they can tell you immediately, is this going to work or not? It cuts out a lot of errors that might be introduced. That even making a stone model from an impression material can involve, if they don't make the stone mixture right, that can involve a degree of shrinkage or change. So the less steps that there are to do something, the more likelihood there is of it being precise. So what we're always trying to do in general practice, especially because it costs us so much to make mistakes, is that we're always trying to improve and reduce our errors. And if we can have fewer errors few of the time, that helps to increase our profitability. Another big advantage of using the digital tools over analog is actually they're very easy to use, and it's faster and less stages, etc., as I've said, but there are no study models. So you don't have the problem of storage, although obviously you have to buy storage as terabytes rather than as physical place to put models. And also for a lot of people, the thought of getting an impression is actually really very scary and upsetting. And the fact of not having to put this goo into their mouth is actually a selling point. Here's what one of our patients said about a recently placed.
Hi, my name is Cheryl, and I wanted to share with you a couple of the reasons that I find the recent technological advances in dentistry has helped me as a patient. The main reason for me is the lack of invasive processes that we now have. Instead of having to have that X-ray plate clamped in your mouth or those dreadful impressions taken where the putty oozes out round the back of your soft palate, it's so much better to just have something that is just pressed against your teeth, even plays a nice little tune. But that for me is so much better. The other thing is as well is everything's so much more efficient. In 2 visits, I had only 12 weeks apart, I had the x-rays taken and my implant fitted, which is just incredible. And as many people are so time pressed nowadays, just making a single visit to the dentist and leaving with your smile intact is just fantastic. Thank you.
So the necessary tools to be able to plan and execute your implant placement are that you need to have an intraoral scanner. You need to have a CBCT machine to take the small volume cone beam. You need to be able to integrate both of those, the scan of the mouth and the scan of the bone and hard tissue. And then you need to be able to design guides. You also, if you want to do everything in-house, you need a milling unit, and you also need a furnace if you're going to produce the restorations. So what does CBCT do for you if you invest in one of these digital tools? It helps to improve your diagnosis. And we are also able to produce guides to place our implants. So what I used to do freehand, I'm now doing with a guide. And it means that I can get the placement exactly where I want it each time and every time, which obviously reduces my error. And it really has been an amazing step forward for me. You can also go very close to anatomical structures such as the sinus, and you can plan to go within 1 millimeter of that sinus floor and know that that is where the implant will end up. One of the big things is getting better diagnosis. This patient attended with a swelling up on the buccal mucosa of the upper left one. And when we took a PA of it, you could see that there was a large area, but couldn't quite see the extent of it until we took CBCT. And you can see there that it is almost into the incisive foramen, and it is also extended through the buccal wall, and it's over the root of the lateral incisor also. So we were able to plan this more cleverly. I was able to do an incision up above the attached gingiva and just go in with a very small incision and clean all of the cystic tissue out. He had root canal done on the 2 and redone on the central. My plan had been to restore this with an implant, but you can see after we did the root canals, then we did some grafting and surgery after the removal of the cyst with ethos. Closed this all up. I think I was going to show you some surgery, but I'm going to skip that. And we folded it up and sutured it up without lifting the buccal mucosa, and you can see here that he got a nice healing. The most amazing thing about all of this is that this was my brother, so I was really very thankful I was able to deliver a crown for him. It's not the perfect crown. This is on the day that I fitted it because he lives in Ireland and he was coming over to get it done, but you can see above the tissue above the attached gingiva, there's not much scarring, and I didn't lose the interdental papilla because I didn't lift a flap. So being able to see better what we're doing and being able to execute the treatment with greater efficiency is one of the great advantages of using CBCT. This patient had a fracture in a composite filling. We thought it was just an ordinary fracture until we took CBCT, and you can see that it's vertically fractured and the tooth is beyond repair. So what we're able to do with her is advise her that that's the case. She decides she wants an implant. So we call this a scan and plan visit. The patient will arrive with a missing their terminal tooth. We take the intraoral scan with the scanner in the mouth. We take a CBCT. We merge those scans. We import the data back into the prime scan, and we can make the guide. So this is Jenny, and she got her guide done, and we then produced, decided where we want this implant to be, placed the implant, then made the crown within a few visits. This is what the guides look like when they're milled out of a block of porcelain. We do that in the MCXL mill, but it comes as part of the CEREC kit. This is her implant on day of placement, and that's it restored. So these are what the guides look like. They're sleeve on sleeve, so it's very accurate. That's for the Astra EV system, which is what this is. And they've also got a little sleeve on it, so the sleeve on the guide drills fits inside the sleeve within the guide, milled guide, and it really produces a very accurate result. I'm also finding that I'm able to do sinus lifts using guided surgery. This patient needed this tooth out and needed some graft material placed in here after the removal of the cyst. But you can see then we were able to put the implant very close to the sinus floor without going into the sinus. So that's it. We ended up having to do a different thing later on, which is why we've got post-op CBCT, but you can see just how close that is to the sinus floor. So it's extremely accurate when we place these guides. So the other thing I use it for is to do a DASC sinus lift, which I make the guide, I plan where I want the implant to be, and then I use the DASC kit to go through and lift the floor of the sphenoidal membrane with hydraulic pressure so that I don't perforate it or tear it. And then it's called a Summers lift, and we're able to do that, and then use graft material to lift up and then put in our implant. And you can see here, this is that implant after placement. This is what they look like on the day of placement. Then that bone material, which is a synthetic material, changes into bone over time, and we get a nice result with that. Another place where it's hard to place implants accurately is in the lateral incisor site, and I've ended up treating a lot of patients with missing lateral incisors. So they get ortho done, and then they come back to us when they're 21 or 22, and we place implants. So again, these are always hard to do without touching the roots of the 3 or the 1, and I don't think that I would be able to do it with such certainty and such security without my digital tools. Patients like the system. This lady came in and she got her implant placed, tooth out, implant placed that day, a temporary, which was just using her own tooth, which I just cut off. You can see it there in the x-ray. We also do a little bit of often a buccal roll flap to increase the thickness of keratinized tissue in cases where the patient's been missing the tooth for a long time. We de-epithelialize the mucosa that lies over the site that we're about to put the implant into, tuck that underneath, put a couple of stitches in, then do guided surgery, and that they only end up with this 2 little sutures on that just to hold that in. So it's very low pain when they're healing. There's a lateral incisor case. I did lift a flap at the top right hand one because I didn't have as much bone. I need to add a bit more bone on the buccal of that, a bit more bone graft material. So that's the patient just immediately following the placement of her 2 screw retained crowns. They're on Atlantis basis and they've been made in the lab, not made by me. I've been treating this patient since she was a baby. So, and she had these missing lateral incisors. We had made Maryland bridges with the digital tools, and then now we've got this lovely result with implants. So for doing the restorations, you need a scan flow, a scan flag, a scan body, a scan post. I'm not going to get into what those all are, but this is what the scan post looks like in situ. And this little notch corresponds with the notch on the little scan body, which corresponds to an isosceles triangle around this outside bit, which tells the machine which way the pieces go together whenever it mills the crown out of Emax. This is the Emax block. These blocks have a little notch in them so that they fit only one way onto the little tie bases that are made for it. So these are called meso blocks, and you can get them in Emax, you can get them in Enamic, and you can get them in some other materials like Teleo CAD, which is for temporaries. Tie base V scan posts, they're different sizes, and that's really just one goes on for the final restoration and one is just for a scanning so that the machine can make and mill the restoration. It's showing you the fit before the Emax block has been centered. This is just to show. Here is a video showing the thing goes together on the prime scan, but I'll not show you that because it's my, yeah, that's for another day when I'm doing a longer lecture. So this is a fitted crown that you can see the screw hole, access hole is in here, and that's an Emax that we've milled and made in the practice. There's a slight difference in colour, but the patient wanted the tooth to be lighter because she plans to whiten her teeth. I don't know if she ever will, but anyway, she was happy with how that all looked. And just allow you to see some of the long-standing restorations where it's maintaining bone, because a lot of people are worried about using tie bases. The only ones we've had debond are ones that we make with Enamic, and I believe that that's because the Enamic is slightly too soft and has too much flex in it, and it's breaking off the cement between it and the tie base. None of my Emax is ever debonded. And you can see here that you've got lovely levels of bone around the implant, and time and again we're getting this. Some of these are 5 years, some of them are 8 years, but they've been over a long period of time. This is what a scan flow looks like, which is one that you send to the laboratory rather than the scan post, which is the one that is for in-house manufacture. Often what happens is that patients come and they see on the screen when we take the scan, they see the extent and how you know, perhaps things are not as aesthetically pleasing. And this lady came, she was coming to get her implant restored. She'd already had it placed, and then when she came back to have it restored, she saw the images of this and she decided she wanted to have both of these teeth, front and back, done as well. So instead of one visit to just put on the implant crown, we get one visit to put on 3 restorations, which obviously is very good in terms of cost benefit ratio for us as a practice, because we're able to be supremely efficient in our time. This patient had a failing failing post-crown upper right 2, the lateral incisor, and we were able to give him some veneers, some crowns, and an implant at the top right. He also got a brace at the bottom and had an implant put in there too. So this kind of treatment sells itself to patients, and he got that done in 2 visits or 3 visits, I think, perhaps. So it really is extremely efficient, and he was very happy with how his smile looked at the end. Another patient, more implants and just aesthetic work. She had had bad perio, which was under control and treated. And she got an implant at the upper right 3, a bridge at 1, 2, and then the 1, 2, 3 at the left have all been veneered. So patients are making choices, and the advantages are that it's a more effective use of your surgery time. It's convenient for the patient. It's predictable. I've been using it now for 20 years. Started off with blue cam, Omnicam, Prime Scan, and I've had the same practice in Edinburgh for 26 years. So these patients are coming back again and again, and I just couldn't afford to do it if it didn't work. So the good thing for me is it works, it's efficient, and I really love learning and using it.
So we go in again with.
We use it as well to plan full mouth cases. We've got some cases here that where patients, we use digital smile design. So that's another form of digital dentistry. We let them have a mock-up of what their teeth could potentially look like. We then, this is his teeth, he's really bad perio, he's in his 70s. And you can see these teeth are just about to fall out. We plan everything. We plan 4 implants at the bottom, 6 implants at the top. The lab speaks to me about it all. We get some guides made and we're able to produce nice solid restorations that look like this, and he ends up being delighted. He goes from here to here. Very happy man. That's about 4 or 5 years ago now. Multiple implants, people come back time and again, so it's a practice builder, reassures patients that we're moving forward. Some of these were done in the old-fashioned way, cement retained, 3 or 4 visits to get them done, and then some done digitally, which obviously takes a lot less time. She's just had another 2 or 3 implants put down at the bottom here, and she will get some eventually at the bottom left as well. And that's been over a period of about 15 or 20 years, so it's not happening overnight, but it just means that you're getting repeat business. This patient came to see us. She was really unhappy with her smile. She had a denture. You can see what she looks like with the denture out. She'd lost her son in a tragic stabbing here in Scotland, and she just used to be a midwife, stopped looking after herself, stopped caring for herself, and let herself go. So we kind of show her what she might look like. This is a close-up of what her teeth look like. You can see she's got a lot of wear at the front. No support at the back, hardly any teeth in contact. And this was her just after her first surgery, where we did all on 4. This was her when she came back, just with her temporaries on. Then we've put her permanents on, do some veneers at the bottom, some tidying up of the work at the bottom, and she ends up being a very happy lady. I would show you this for my staff, but I think I'm kind of running out of time. But they are very engaged with the whole digital process, and they have really enjoyed learning and using digital tools. We'll finish off.
Hi, my name is Hannah. I've been a patient at Bite Dentistry for the last 5 or 6 years. I first came to see Eva in 2015 when I got my bridge fitted, which was a really good experience, really smooth, and I had a great 5 years with that bridge. But I think the ultimate goal was to have an implant fitted. I was just waiting till I was old enough. So in the beginning of this year, that's exactly what happened. I first went to see Eva at the end of January, and I had scans and x-rays done, and the implant was fitted. It was a really simple procedure. Eva explained everything to me, and yeah, it was great. And then I had to wait a few weeks, I think, for that to completely heal before we could complete the implant, put the crown on. So I came back in April, and it was just so simple. It was one appointment. I came in, I saw Eva first, checked everything was all right, and then I sat in the waiting room for a bit, and when I came back, they just magicked this tooth out of nowhere, which was brilliant. So I've now had it for 6 months, which has been amazing. I finally can eat apples and corn on the cob and crusty bread, and it's great. So yeah, I've had an amazing experience with Bite Dentistry. Everyone there has been so lovely, and I won't change any of it. It's been great.
So In fact, today I was at work and this boy, Robbie, his mum came to see me because he was 27 yesterday, and we worked out it was just before his 21st birthday. He was playing hockey for Scotland and he got this injury. And this is the photo that they sent to me on the left, which is he was wearing a gum machine, believe it or not, but got hit in right on the face, and he broke his anterior maxilla as well. So he broke the bone at the front, as well as taking out one tooth, which is the upper right one. He also fractured off multiple teeth, and the worst one was his upper left 3, which was fractured beneath the gum. Now, would you believe that we were able to replace all of these with digital dentistry, and the only one that he actually has a crown, oh no, sorry, he's got crowns and veneers on these front ones, but the only one that he's actually got an artificial tooth and an implant on is his upper left 3. So the other 4 anteriors remain to be, we put them back in again. He got them root filled and they're still there. So his mum showed me a photo today, which actually I should have added to the lecture to show you, because she actually said to me that looking at his teeth, it just looks like he never had anything wrong with him. And he recently played for Scotland in the Commonwealth Games, and she doesn't believe that he would have done that if he hadn't been able to get his teeth fixed. But the most amazing thing, even to me, about me fixing these teeth was that he was able to get it done in 3 or 4 visits from this to this, and still have all of that intact. So if you want to get involved in digital dentistry, I think it's logistically very easy. It's emotionally very engaging. Psychologically, for the patient, it's much easier for them to deal with the treatment because it's quicker and it's less invasive. Physiologically, it is good for the patient because with the advent of EMAX and being able to put implants in, and the hemidesmosomes being able to attach to EMAX crowns on a screw retained basis means that it's very biologically compatible, and we are not seeing any major bone loss or problems even after 5-10 years. It's more economical, not for the patient, obviously they pay a premium, but for us as dentists, we can provide the solutions in a more economical way, both by taking less time and by, once you've invested in the capital purchase, then all of the materials are a lot cheaper. But most of all, it's ecologically sound because we don't have to send things backwards and forwards to laboratories. So you're not having the same amount of postage and, you know, passing transport costs, etc. I would show you Penny, but I think we've just about run out of time, and I've probably told you enough about what the benefits are. But one of the things to ask before you invest in the scanner is it going to improve or keep patient care at the same level? Is it going to give them a better experience? Are the company that you buy it from going to help you to implement and give you support so that you can actually not leave it sitting in the corner to gather dust? Will your team be able to get involved, and how easy is it for them to get involved? My team do a lot of the scanning, both with the CBCT and with the Prime Scan. And most of all, but the most important thing for us always is, will we get our return of investment? And the answer to that is yes. And of course, the biggest saving is time. I'll not show you that photo. That was at a party. Thank you and enjoy the scan. And if you do want to contact me, my email is emer@bitedentistry.co.uk. It has been my pleasure to be here with you today and to talk to you about the benefits of digital workflows, especially in implant dentistry. And I hope that some of you may decide to invest in this amazing technology, because from my own perspective, I have found it to keep my job interesting, and it has definitely made my practice as successful as it possibly can be, because patients keep coming back for more and more treatment and they tell their friends. And because I live and work in the same place and have stayed here for a long time, that of course is good for the business. So thank you very much for the invitation to speak, and any questions can be directed to me at emer@bitedentistry.co.uk. Thank you.
Thank you, Dr. Imar. I'm calling her. There are 3 questions here. And if she is online, I would like her to answer this question. We will wait for some small period of time for her to connect if she is online. guess she's not until now, and even now is not. Anyway, we could say there are 3 questions. Generally, the technical things. What digital scanner mistakes possible in dentistry? Which digital tools make more mistakes, and which tools can produce mistakes? And then, which digital scanner system do you recommend? Which manufacturer? Digital technology, of course, help us all. We know that all, and it is very helpful. Besides, then you can talk about economical level using these machines, and it depends from country to country. Of course, it's not same for all. The other thing, there is no machine without mistake. Mostly for this, as I know, it's a problem with software sometimes. So I will only discuss. I'm not the guy who will lecture these things, but I will try to discuss it a little bit. I'm sure 2 things. If you buy some systems, you have to first to buy from well-known company, and you have to know that how cannot support you, to background you. If something's wrong, how they can help you. This is the 2 things for sure. So I'm very sure it helps a lot. This digital technology, scanning and everything, it's very accurate, mostly very accurate. But it's always have to be some percentage of retreating a little bit and look at all the other things, not to think about that it is accurate 100% all the time. So it could happen. It could happen always. Any machine can do it. But mostly it's very helpful. It's very helpful, very fast. It spares your time in dentistry. The other side is the patient's luck. Of course, any patient like this technology, machines, and he thinks it's always better. It is, of course, better. But I cannot say which software, which company can help you more or less. I'm not the guy who can tell this and promote some of these things. I'm calling Dr. Emer. If she's online, I'm waiting. It should be nice if we can hear her, or if she could answer. She's better than me, of course, in this field of technology. Probably has more experience than I. So my personal things I just answered because there is nobody around, so I try to do it. Anyway, thanks a lot to Dr. Amar. So nice presentation. And next will be at noon. Professor Giulio Rasperini from Italy, the total oral implant care concept. It's going to be start in noon, 12 o'clock in the noon. If Dr. Amar is well connected during that time, I will be here waiting for that. Then we can talk a little bit about this. Even I'm personally interested in some of details about this scanning technology, these things, because we're living by the Europe, and then sometimes we will have problems, just in general, that's back up with a technician, problems with software and the things as usual, as anybody. And for us, that will be more important sometimes in the position that we are. So that's it. It would be nice if she can help us to maintain some of these questions accurately or precisely or generally better. Okay, we're gonna wait to see Dr. Professor Giulio from Italy. Benvenuti professore in questo nostro congresso, 10 congresso. Noi siamo molto. Yes.
They say life carries on and on and on. Life carries on in the people I meet, in everyone that's out on the street, in all the dogs and cats, in the flies and rats, in the rot and the rust, in the ashes and the dust. And life carries on and on and on and on. Life carries on and on and on. It's just the car that we ride in, the home we reside in, the face that we hide in, the way we are tied in. And life carries on and on and on and on. Life carries on and on and on. Did I dream this belief, or did I believe this dream? Now I can find relief. Agree. It was only 1 hour ago. It was all so different then. There's nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. Now there's no one home. I agree. news that truly shocks is the empty, empty page, while the final rattle rocks. It's empty, empty cage, and I can't handle this. I'd for you. And you leave me. Let it out and move on. Missing what's gone. They say life carries on. They say life carries on and on and on. Life carries on in the people I meet, in everyone that's out on the street, in all the dogs and cats, in the flies and rats, in the rot and the rust, in the ashes and the dust. And love carries on and on and on and on. Love carries on and on and on. It's just the car that we ride in, the home we reside in, the face that we hide in, the way we are tied in. And love carries on and on and on and on. Love carries on and on and on. Did I different end. There's nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. Now there's no one home. I agree. For you, you it's so hard to move on. Still loving what's gone. They say life carries on. Carries on and on and on and on. The news that truly shocks is the empty, empty page, while the final rattle rocks. It's empty, empty cage. And I can't handle this. I'd read for you. And you me. Let it out and move on. Missing what's gone. They say life carries on. They say life carries on and on and on. It's just the car that we ride in, the home we reside in, the face that we hide in, the way we are tied in, and life carries on and on and on and on. Life carries on and on and on. Did I dream this belief, or did I believe this dream? Now I can find relief. Agree. It was only 1 hour ago. It was all so different then. There's nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. Now there's no one home. I agree. For you, you leave me. It's so hard to move on. Still loving what's gone. They say life carries on. Carries on and on and on and on. The news that truly shocks is the empty, empty page, while the final rattle rocks. It's empty, empty cage. what's gone. They say life carries on. They say life carries on and on and on. Life carries on in the people I meet, in everyone that's out on the street, in all the dogs and cats, in the flies and rats, in the rot and the rust, in the ashes and the dust. And life carries on and on and on and on. Life carries on and on and on. It's just the car that we ride in, the home we reside in, the face that we hide in, the way we are tied in. And life carries on and on and on and on. Life carries on and on and on. Did I dream this belief, or did I believe this dream? Now I can find relief.
Thank you, dear friends. This is Giulio Rasperini, and I'm sharing now my screen, and thank you for the kind invitation to this meeting. And I will talk about the oral implant care concept. And so I want to start with the story of this student that she was my patient. She asked me, Professor, I've lost these three teeth during a car accident when I was younger. The teeth were reimplanted, but then I had root resorption and I've lost the teeth. So in this case, in 2005, I had the possibility to work and to test the PDGF from United States. Actually, it never came to Europe, but I used the proteinized bovine bone mineral. I used a titanium reinforced non-resorbable membrane. I placed a couple of pins, as you can see. And so I did a nice regeneration only with the proteinized bovine bone mineral and growth factor. And you see with the membrane doesn't touch the teeth, and I stabilize the membrane with 4 pins, 2 lingual and 2 buccal. That's it. After 6 months, I recalled the patient, and the patient looks like this, so it's much better. The orthodontic appliances are only to keep the provisional. So the provisional, they don't give pressure on the regenerating area. And when I remove the membrane, this is the clinical situation. Do you remember where 100% the proteinized bovine bone mineral and few drops of growth factor with the non-resorbable membrane? And the result is very good. You see, it's a significant vertical ridge augmentation. It's 5 millimeters vertical, and also the thickness is good. And as you can see, this is a real horizontal because we moved the bone horizontally from an apical position to a coronal position. And so we did the histology to prove that this was newly formed bone. And you can see this is a particle of non-resorbable or slowly, let's say, resorbable bios. And this is the newly formed bone and the activity, the cellular activity in only 6 months. And so when you see this, and if I stop here with this presentation, you say, wow, this is a good regeneration. And you see the vessels, there are no sign of the particles that were before. This is all vital. And now we can place the implants. But if I continue to show you this case, and I show you this X-ray, now we are in November 2006, and we need to re-entry, and we place the crowns. And now this is January 2007, when we finalize everything. The patient is super happy with her new smile. But in September 9, you see, everything is still good. There is a little bit of bone loss here to the lateral side. And this is February 2009. And the patient is still happy. There is no suppuration. Everything is doing good. Now, of course, we continue to follow our patients, also because she's a dentist. So, but not only for that. And so this is September 2010, July 2012. You see there is a recession now here on the central incisor. And now the patient disappeared for a while. And now we are in February 2017. In February 2017, look, we had to re-entry because there was bleeding, there was suppuration and near here, and I could probe. So as you can see here, there is a big inflammation. So we raised our flap. You see the implant is a little bit too buccal. You see the implant is too buccal, and this is an implant with a T-unite surface. So it's a rough surface is implant. So also with the laser, we try to decontaminate the implant surface as better as we could. And this is the situation. Both implants try to raise a flap, smart, not to elevate too much, to not to be able to give stability at the end to the area. So we understand the anatomy of the implant. We know exactly how it is also behind, so we can clean also behind the implants, also in the palatal aspect, without raising the palatal flap. And so this is the second implant, the one on the central. We try to clean as better as we can. We place few granules of regenerative biomaterials, and we close as better as we can. Now, this is July 2018, so it's 1 year after. Doing pretty good, but after 2 years, April 2018, now there is a separation. So basically, it's June 2018 when we wear again the orthodontic appliance, because we are going to remove this, and we will place the provisional for this, because we had to remove this implant now. Is after 12 years, as we started all the process, but still 12 years can look like a very long-term result, but it's not. If you consider the money that the patient paying, what she had do for it, and she's still young. So when we see the area and we can probe, as you can see, we can probe deep. So we start to remove the first implant. You see the first implant is completely removed, and we clean the surface of the epithelium that is inside. We remove with the scalpel, and we apply some Bios collagen, and we place collagen sponge on top, and we create a cross suture to stabilize everything. And we do exactly the same with this implant. So we remove also the other implant, we do the same. We wait for a period of healing. And as you can see now, we can, then there was COVID, we had to postpone a little bit the procedures, and now we can plan, now in a completely different way. Now we want to place the implant in the proper position, so we decided to use the implant. Now we don't have anymore these implants, but we have the iris implant that are hybrid implants with the machined surface in the third coronal. So we can plan. This is a service that is offered. They help you to plan the position of the implant perfectly, and you can prepare on the base of this surgical guide, a stand, so you want the implant completely into the bone, perfectly in the middle of the alveolar process, as you can see. And now you can ask to the person that will prepare the stand to move to place. I mean, together you decide where exactly to place the implant. And I like the implant a little bit into the bone, 1-2 millimeters into the bone. I like to use the internal hexagon. And so we decided to add this type of positioning. We need to use a 3.3 implants by 10 millimeters. And this is the implant 12. And this is for the implant 21. Again, a 3.3 millimeter diameter implants and a 10 millimeters length implant. And so we have now the surgical guide. And with the surgical guide, we can apply the surgical guide to our patient. And this is the hybrid implant that we can place now. So with the rough surfaces, more apical to allow the faster osseointegration apically, but for the third coronal, we like to use a machine implants that we will discuss soon what is the reason. Again, it's everything to prevent perimplantitis and to promote long-term success rate in our implant cases. And this is the first implant completely placed, and now is the second one completely placed also. So the good thing that applying this technique, you really are minimally invasive. You don't need to make any incision that we will damage the papilla. If you make an incision, you will damage somehow the papilla and the interproximal attachment of the lateral and the canine. So we can just with the punch technique, because we have a lot of keratinized tissue buccal. When we do the same approach in the lower jaw, we don't have so much keratinized tissue. So often you need to make an crestal incision and to preserve the soft tissue, the keratinized tissue. In this case, we have plenty of soft tissue, so we can just make this type of procedure. And this is the situation with the healing abutment. And now we can take an impression and prepare the provision. Now the tissue have to mature, but after the tissue mature, you understand that the height of the papilla is not as you would like to have. So you see, we have the tissue is very thick, very nice, I have to say, and we can conditioning this tissue in the middle, but still we have in this area, as you can see, lack of soft tissue. And if you plan prosthetically the position of the teeth, you understand that this is how the papilla should be, and we have lack of papillas, and we miss like 3 millimeters of papilla in the middle and 4 millimeters of papilla between the central and the lateral. So we go back surgically, we harvest a piece of connective tissue graft from the palate, and we advance the flap coronally. In this way, you can see through this incision, you see there is an incision apical. We place the graft buccal and crestal. And with this suture, we help the tissue to stay nicely coronal. You see where is the positioning of the tissue at the end after the maturation. I like to wait 2 weeks before to remove the suture, and sometimes if there is still tension, I wait also 3 weeks before to remove these sutures. And so when the tissue is stabilized at the end, you see it's more coronal, and now you can say maybe it's a little bit too much tissue. This is when we remove the sutures. You see now it's ugly because there is too much soft tissue, and this is a nice problem to have. And now we can say, okay, we have a little bit too much tissue, so we need to remove a little bit and to conditioning the tissue at the level of the papilla and to consider the zenith of the tooth. So we have the implant, and we know that we want to have the soft tissue here. We create this zenith to stabilize our soft tissue in this area. And this is how it is. And so you work after, once the tissue is healed during the maturation phase, but the tissue should be completely healed. Otherwise, if you make pressure on the tissue before the final maturation, you will lose the tissue rather than to conditioning. And also when you push the tissue mesial and distal, you improve the interproximal tissue. But if you press the tissue buccally, then you create a recession, okay? The margin is the critical area, and from the supercresta soft tissue in the apical part, you have the subcritical area. The subcritical area is the area where you can create the pressure after healing. Working with the provisional, adding composite and modifying, we can move from here 1 to 2. You see, we did a little bit of plastic to improve the quality, the look of the tissue, and now we have a nice papilla in the middle and nice growing papilla in this area too. And now we can take the final impression, giving to the lab technicians the proper position, and this is how the tissue looks like. And we started, you remember, from here, and now this is a different angulation and different angulation. And so we have a nice amount of soft tissue to conditioning, to boost, and to create our soft tissue. This is the final case and the final smile of the patient. And now we maintain this case with continuing X-rays and control like every year, and hygiene every 4 months. Of course, we recommend her to do in her own office, because we know that peri-implant complications are very frequent. In this paper from Berglund and Armitage in 2018, we know as a case definition that when there are cases with a sign of inflammation, erythema, and swelling, we already have a mucositis or perimplantitis. When there is bleeding and suppuration or on a gentle probing, that means we are not anymore in health, we are in mucositis or perimplantitis. When there is an increased probing depth versus the previous examination, then again, we have a mucositis or perimplantitis. And when there is a bone loss behind the initial bone remodeling or previous evaluation, again, we have perimplantitis. So perimplantitis, if you go back and you check on PubMed, when was defined? In the early years, before 2000, let's say, but let's say before 2008, was pretty rare. Started to be discussed after the 2000, 2002, 2004, when rough surfaces implant came on the market, honestly, because before there were at the time, the Brånemark implant, that they were with machine surface, as well as the 3i and all these pioneering implants were the machine surface, or there were the tissue level implants with the smooth collar. And we will talk about this. And you see in the most recent year, how many studies that we have every year on perimplantitis, because it's becoming a big problem. During the 6th European workshop on periodontology, there was in 2008, there was discussed as a perimucositis, the subject were 80% and the implants the 50%. And perimplantitis was between 28 and 56%, and between 12 and 43% of the implants were involved. Nowadays, after this review in 2016 from Derks, we find out that 77% of the peri-implant disease can be divided in mucositis and perimplantitis. So it's in 596 individuals after 9 years X-rays and clinical evaluation. So it's a huge number of cases. And also Mario Romandini, he published this in 2020, this data where on 99 patients and 558 implants, he could see 35% of the patient and implants had perimplantitis with a bone loss between 1 and 2 millimeters, but 56 of the patients and 27 of the implants had perimplantitis with a bone loss more than 2 millimeters. And as you see, the progression is a non-linear accelerating pattern. You see in this case, for example, 2003, 2005, 2007, 2010, and 2013. You see, like in a few years, as let's say, all the supracrestal apparatus doesn't have anymore the possibility to create a ceiling in the coronal part, and we reach the apical part with the rough surfaces implant, you see as their perimplantitis progress more quickly, and as the pocket becomes deeper and quicker, the progression of the periimplantitis. And of course, there are plenty of evidence in this meta-analysis about the perimplantitis progression is faster in moderately rough oxided surface compared to the turned surface. So when you have a machine surface of the implant, the progression is very slow, but when you have rough surfaces implants, the progression of the perimplantitis gets faster. As well as the treatment, of course, there is a better answer to the treatment when the implant surface is machined when compared to the rough surfaces implants. This is a very important point because we can actually prevent the perimplantitis, and we can do something for that. So the implant, first of all, also we know that the implant is, the success is lower in periodontal patients. So first of all, we have to make the periodontal patient healthy and try to save all the teeth that we can, because if in a periodontal patient we extract teeth too easily, those patients also have a higher risk to lose implants as well. So try to save the implants in the teeth, in these patients, and try to fight with the periodontitis to remove completely the inflammation in this patient before to place the implants. And So we can select a proper implant. Again, this is the type of implants that I prefer with collar, and not is more than a collar, it's a hybrid implant that have the coronal third completely machined. And there are over 700 implants on the market that you can choose. But now, if you follow my concept, we know from Baralou in 2005, he wanted to culture the epithelial cells because the ceiling on the implant is due to the keratinocytes, so to the epithelial cells. The epithelium create a ceiling on clean, smooth surfaces. And these are keratinocyte epithelial cells, and Baralou made them grow on these different type of surfaces. This is tissue culture plastic, very polished, and then titanium coated, and then polished T-coated, and then acid etched. So this is a rough surface, this is more rough, and this is even more rough, the grade blasted and acid etched implant surface. And you see how the number of the cells is reduced. More the surface is polished, is smooth, and better the epithelial cells grows. And also the diffusion of the cells is more when the surface is smooth, and less diffusion of the cells in very rough surfaces implant. And more roughness increase the surface cell wall distance. For example, in this graphic, you can understand when the surface is rough, the cells have very little contact. When the surface is polished or machined, so very flat, there are many contacts that the epithelial cell can create on the implants. So this is a good contact and create a good resistance to the biofilm and to prevent inflammation. And there is this interesting study. This is a study made in dogs from Thor Berglund and co-workers. You see there is Klaus Lang, Jan Linde as well. And what they did, they used the regular Straumann implants. This is a regular Straumann implant, and this is a polished Straumann implant. So it's not polished only, it's machined Straumann implants. And you can see the implants both completely osseointegrated with the crown, and the dog can chewing. So this is a polished, is a smooth surface, and it's osseointegrated, and the dog can chewing. So why we always need these rough surfaces? Because when we put the ligature in the dogs to induce the perimplantitis, as you can see, we induce the perimplantitis in both. But when we remove the ligature, in this day we remove the ligature, and you see the progression continue in the rough surfaces implant, and in a machined surface implant, what happened? The dogs, they clean the same. They don't clean. The first dog and the second dog as well. But here you can see for the bacteria is more difficult to accumulate, but for the epithelium, it's easier to recreate a new attachment. And there is like a self-repairing. And this is published, so you can see these histologies, but what not published was the image of a polished surface. You see, this is a polished titanium surface, and this is the Straumann, completely polished, and this is the typical Straumann implant. And you understand that both osseointegrated and both were able to function for the dog. You see, have you ever seen a polished implant like this? And this will osseointegrate anyway. So the big difference is, can I load the implant? Can I put my crown 2 weeks before, 3 weeks before, a month before? This is the difference. This makes you to risk the progression of perimplantitis rather than to have this opportunity, because you can load an implant 3 months before, 1 month before, or is more important that the implant maintain the healthy situation for 20, 30 years. And also this study from Carlos and Garoica Pasmino and a co-worker. I'm friend with Carlos Cararquez. And also in this systematic review, they noticed, like I'm showing in the conclusion, that the turned implant surface, so machined, presented with the least amount of bone loss over the 3-period evaluation, and also the rough surface implants surface modified by additive methods demonstrated the greatest amount of bone loss and in the period of observation. And also for the treatment, of course, of the perimplantitis, have a better prognosis with because it's easier to clean them. Another very important issue is the soft tissue. We don't have much time. I'm almost done, but I want to underline with you this concept that started from this histological study from Thor Berglund and Jan Linde. They made a thick supercrestal tissue on the bone around the implant, and they made a thin soft tissue around the implant. And what happened? Always, 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 you have 2 millimeters of epithelium and over 1 millimeter of connective tissue, and then you have the bone. In both cases, what does it mean? It means that if the tissue is only 2 millimeters, it will recreate 2 millimeters of epithelium over 1 millimeter of connective tissue. That means that the bone will resorb. So when you have the marginal bone loss, is because the supercrestal soft tissue around the implant should be able to keep the 2 millimeters for the implant and 1 millimeter at least and more for the connective tissue. That means the supercrestal soft tissue should be at least 3-4 millimeters. If it's not, you will have marginal bone loss. And if you start with a marginal bone loss and you have a rough surface implant, you're done. The epithelium will never be able again to create sealing. So what you can do is to make the soft tissue thicker, or you can place the implant a little bit more into the bone. And then this concept was taken again from Linkevicius years after, in 2015, where he showed that when you have a 2 millimeter, this is a not histological, is a clinical study. When you have a thin phenotype, less than 2 millimeter, or you have a thick phenotype, more than 2 millimeters, what is the difference? The difference is that you can see marginal bone loss. You see, you have marginal bone loss. In case of thick tissue, you don't have marginal bone loss. And so they say there is a difference. This is the difference in terms of bone loss in thick phenotype and thin phenotype. You see, in thin phenotype, you have much more loss of bone. Now, if we make this tissue thicker, how will it react? And we know that if you make the tissue thicker, will react exactly like if the tissue was always thick. So that means you can make the tissue thicker and it will work like if the tissue was always thick. So no marginal bone loss. So it's a clinical recommendation to do that. And you can both augment in the first stage or in the second stage. And also in this systematic review, the group of University of Michigan with Amelie Wang showed how it's important, the thickness of the tissue. Now, very important when we analyze the emergence profile, the implant position plays a very important role, the suprastructured prosthetic design, and the soft tissue. but I want to now concentrate a little bit on the soft tissue, how to improve. On the vertical, when you want to improve the tissue vertically, you can use the tuberosity, because this tissue have the tendency to continue to regrow. So for papillas, works very well. When you need to increase the tissue horizontally, now you need to go on the palate. And this is, for example, when is the best moment to place the connective tissue graft? Every time you do a surgery, you can take a chance to improve the quality of the soft tissue. You can do also more than one. You can do during the implant placement, you can do during the second stage, and even after. So the tuberosity you leave on top, so will grow the papilla, and the connective tissue graft you place from the palate, you place buccal. You see, for example, this is a tuberosity harvested connective tissue graft. You see all around the healing abutment that is placed in the area, as well as here to recreate this papilla. You see, this is a piece of tuberosity sutured on this parcel thickness flap periosteum and connective tissue left on top of the bone crest. You see, with different sutures in a way that is very nice and stable. But buccally here, we can place a connective tissue graft harvested from the palate. Okay, you see, it's a synergic. Very often when we do immediate post-extractive implant placement, we improve the quality of the soft tissue here, and we prevent the recession, always placing a little piece of connective tissue graft here buccally, sutured with mattress suture and nicely stabilized. So I didn't have much time, but I think I went a little bit in details on this concept for me to prevent the perimplantitis and to have a nice, stable soft tissues. First of all, the implant selection. And the implant selection, you have seen, I like to use the hybrid implants and to place the implant a little bit into the bone. It's very important. The bone, of course, for the implant should be completely into the bone, and then the connective tissue should be thick, and the epithelium is very important because the sealing is thanks to the epithelium, where that follow and cover the connective tissue needs at least 2 millimeters the epithelium on top of the supercrestal tissue. And we can make it thicker with connective tissue graft harvested from the tuberosity of the palate, but we can use also matrices, as you have seen in the photo that I showed you from Linkevicius. We can use matrices when you only need to increase the thickness of the tissue. But if you need to change the alveolar mucosa into keratinized tissue, you need to use the connective tissue graft. Now, it's very important to study, analyze, and develop the emergence profile and the angle of the teeth. The implant position is super important. It's very important. That's why nowadays, very often, I like to use the guided surgery, and it's very nice. You can do by yourself in your center, but for example, I use the company that I use the implant with also helps me with that, and we can develop together the guide for our surgery. Silver plug is an additional concept. It's like a cork to seal the access for the screw to the stabilization, because this will seal is like a cork with some silver particles that doesn't allow to the bacteria to stay inside. So keep this area sterile and to prevent periimplantitis in the future. So there are, and then of course, you need to set a maintenance program for these patients with instruction for oral hygiene, and they should not smoke. They should keep under control their diabetes, and see the patient regularly to keep this patient healthy and this implant healthy over the time. I hope that was not too confused, because in little time I have so many things to tell you, and we can keep in touch through Hyperio if you like to visit us. And I want to thank you for your attention. And if you have questions, I'm available. Thank you.
Professor, thank you very much for your presentation. Very, very good lecture. I don't see, yes, I can see you. Just technical problems.
Yeah.
If you're online, yes. Thank you very much.
Hi.
Hi. There's some questions, as you can see on the right side, Dr. Philip or something. They're asking you,
No, I don't see the questions. If you can read for me.
Okay, I'm gonna find it. Yes, I'm gonna find it for you. Your lecture, of course, is really conscious and takes a different view of this implantology and solving the problems. This is very, very useful for me and for my colleagues, I'm sure. Some questions is, do hybrid implants have to be placed in the same depth as a polish in relation to the crest bone level? So is there any difference between placing the hybrid implants to the other standard or classical type of implants? There's a question written.
Thank you for the nice questions. And we were discussing this also with Danny Boozer at the Schulian Boozer Symposium 2 days ago in Bern. And okay, the depth is more related to the connection. If it's an external hexagon, of course, you cannot put deeper. You need to stay at the bone crest. Now, if you have an internal connection, nowadays the tendency is to place the implant just 1.5 millimeters deeper to the crest. And I'm talking not about the mesial distal, but I'm talking about the buccal. So that means mesial distal maybe is a little bit more, because there is this tendency. And but this is not by the fact that these are hybrid, because actually the fact that are hybrid with a machine surface currently, they forgive more in case of the epithelial attachment need to be more apical. But because you want to have your implants that stay healthy for at least 20 years. So we are not focused to have a beautiful immediate case, but we want to have a beautiful immediate case long term. And so the patient will have the tendency to lose bone. Doesn't matter how you try to preserve, but if you place an implant in a 50-year-old guy, then when it will be 70, his bone mass will be reduced. And so it's automatic, it's like natural that the implant will stay in the same position. So the bone reduced, that means the coronal part of the implant will be exposed. So it's better to prevent this, placing the implant a little bit deeper. So for example, in a lower jaw, distal, it's better to place an 8mm implants 2 millimeters into the bone rather than a 10 millimeters implant exactly at the bone level, if you use internal connection and conus.
Yes, thank you. Thank you, of course. It's understandable. The point is, like it was before, we had this lateral resorption of the bone around the implant. It's called physiological triangle, as it was long ago when they used to start biphasical implants, monophasic, but then biphasic. It was loose a little bit like a triangle around. Does it affect something like this with this smooth part? Is it the same? Should be statical problem. I don't know, but the question is.
This is due to this is due to different thing. This is due to the thickness of the soft tissues. On top, if you have keratinized tissue, you remember the study from Berglund and Linde, 1986, the histological studies in dog. They showed that if the tissue was thick or the tissue was thin, always you have 2 millimeters of epithelium that need to be attached. Then you have 1 millimeter and a little bit more of connective tissue, and the soft tissue on top, that is 2 millimeters, you will have bone resorption. It's not physiological. It's due to the fact that the supercrestal soft tissue, so let's call attachment, I mean apparatus per implant, soft tissue apparatus supercrestal, he need to be 2 millimeters for the epithelium, 1 millimeter for the connective tissue. So that means the soft tissue should be thick at least 3/4 millimeter. When it's not, we can increase the thickness or with matrices or with connective tissue. Or also placing the implant a little bit deeper, that you create a little bit this distance. This is also the concept that also Linkevicius did a lot of publication more recently than Berglund and Linden on this concept.
Yes, of course. There is no physiological loss of the bone. It's pathological always. They be named maybe.
Yeah.
50
It's
years
due to
ago,
the thickness of the soft tissue.
Physiological, but it's not.
Was considered physiological. You're right.
Yeah,
You're right.
It was named like this. I said never. If you lose bone, it's not a physiological. Even the peritopathy, we have some loss of the bone of the old people. It's not a physiological. It is a repercussion when you become old, right? Senile.
Yeah. Something
loss of the bone. Who says it? There's no physiological. That was all the time. So I do understand. I'm looking. Yeah. Is there the other question? There is a doubt. I know what's going on because I was doing some implants which were smooth, and it was smooth and it was a disc implants. So I have experience with this. But the question, I want to tell you the question. Is there doubt, or who knows what is going on, or you will answer, of course, that osteointegrate is the same osteointegration on the smooth surface as similar as it is on the rough one? Is it the same?
Yeah. Look,
I know.
In the first 10 years of my implant life, I mean, as implantologist, from 1990 to 2000, I was using machine implants. All the implants were machined. And these implants are still in the mouth of my patients. So 30 years ago, I placed the implants and they're still in the mouth now. And when someone says, okay, you have more risk of immediate implant losing because they will probably not osseointegrate, but you have to remember that those implants 30 years ago were completely different. The external hexagon, also the micro surface was different, etc. And so actually the osseointegration, you have to think that all the first studies on all-on-4 that Paolo Malò published, they were with machine implants. And they were all on 4.
Yeah.
And these implants were machined. Who says, yes, but with rough surface, you have a better bone implant contact, the famous BIC. But actually, the question is, how much bone implant contact you need, that when you have an implant that is osseointegrated 2 millimeters, is so hard to remove it. That probably we don't need this bone implant contact like so much. And it's more than enough. Is the implant more studies are completely machined, are the ones that have the most long-term success rate. And so actually with the hybrid, is we give them the possibility to load the implant a little bit earlier with the rough apical part, which is more than enough. But the coronal, we can keep it machined, and he will osseointegrate like always did the machined implants.
Yes, of course. This is I was doing this discoid implants and it was broke. I have to take it out. It was not possible without drilling. It was absolutely was contacted, osseointegrated, and it was smooth. I don't know, titanium first grade or something like that, old type of titanium, and it was not possible to remove it without drilling. So it was osseointegrated, of course. So I'm looking for, is there any question?
I see beautiful photos on your background that going
Yes.
on. I mean, you had a nice party. I mean,
No, it was always.
Too bad I'm here in Italy.
I'm sorry.
Next time I want to be there in
Yes,
person.
you have to come here because it's always, our Congress is always better face to face than online, and you will see the photographs of this.
Please.
So thank you very
Please.
much. Thank you very much for your extraordinary lecturing and presentation.
Oh, thank you.
Thank you in the name of my colleagues and all the viewers, and see you soon. I hope.
See you.
See you.
Thank you, Professor. Thank you very much.
Thank you.
Thank you. Goodbye.
Hello.
Bye to everyone.
I'm just calling, and at the same time you can stay. I am calling Dr. Amar from Scotland. She was busy while she was having
Hello.
her lecture. Hello.
Hi. How are you?
Hello, Scotland. What's going on beside whiskey there?
Well, good morning. I was treating my mother, actually. Her implant crown had come loose, so she had come from Ireland. I had to fix it, so sorry.
Okay, no problem. There were some questions for you, so just I was trying to answer myself. I'm no specialist for that technology as you are. That's why I'm thinking of. I will tell you first. There are some questions I'm gonna read it for you. Are digital scanner mistakes could be possible in dentistry? It could be possible mistake.
Yeah, you can make mistakes, but if you're careful about your scanning, as you would be if you were taking a silicone impression, then the accuracy is now really well established, and we have got as good accuracy as a silicone impression. In fact, better if you imagine that you're doing it there and then lifetime and immediately go into the restoration. Most of the restorations that we produce here are in-house, and you can produce them first of all in the Emacs before it goes through the oven. So you can actually, if you're really not 100% sure it's going to be perfectly accurate, you could try it in before it goes through the oven to get glazed. But to be honest, now the accuracy is so good that we just put everything, we prepare it, put it through the oven, and it comes out and it just fits beautifully. So it is an exceptional tool to be able to use. The one thing to be careful of is when you're scanning interproximal space, trying to get the mesial and distal contact point, if you've got a very deeply placed implant, can be a little bit more challenging. But if you've got a good scanner, it's still really accurate. And actually, in the laboratory that I work with, they have many fewer refits and many fewer retakes with people that use digital technology, even just for the impression part, not necessarily to do the whole in-house workflow, even just to send it off to the laboratory instead of a silicone traditional impression. So it definitely is a worthwhile investment.
Oh, very nice. Of course, this is a machine. A machine can make mistake like man. So you have to be careful. Like,
Depends who's using it.
could be, but of course less normally. But it doesn't work without hand and man. The other question, it's same about mistakes. Which digital scanner system do you recommend? Which manufacturer or something? What brand or something?
I suppose, I mean, I need to tell you that I lecture for Dentsply Sirona, so I am one of their key opinion leaders for their digital technology. So obviously, I'm most familiar with their scanner. So the latest scanner is Prime Scan, and actually, if you look at the studies that have been done, it is the most accurate scanner currently on the market at the moment. However, 3Shape and Itero are not really far behind, so and Trios. So you know, there's multiple scanners now that are excellent quality, and I guess it depends what you would like to use it for. If you just want to take impressions with it and send to the laboratory, then almost all scanners are accurate enough for that. If you want to do a full arch restoration, then you need to be using something much more accurate. So Prime Scan or Trios are probably the two best at the moment on the market. As shown by, there's a guy, Wally Remy, that studies, and Mark Ludlow, that have produced a lot of studies from the university. I think Mark Ludlow is currently in University of Utah, but they've got lots of studies about digital scanners, so you can read those studies and you can see for yourself the evidence. So
I was, acting you while you've been busy. I try to, by my knowledge, experience, I just try to answer. The other question is, I think it's very important when you choose the brand or company to buy it, what is background support you have?
Yeah.
You have problem that you will have because you have immediately problem. You don't have for tomorrow problem. You will have now, and now you need help. So I told that's probably very interesting if you buy something to try the best quality as you can, economy and other problems is, and on the other side, you need the best backup in your country. So this is EU, I'm not in EU, somebody's somewhere in Africa, who knows? Yeah. So it's always important to have a good backup that we can help you, especially software could bug or something, and patient want the tooth for tomorrow, of course.
Absolutely.
Yeah. So that I told, probably you agree with this.
Yeah, I mean, we pay a contract for software support so that we get the continuous upgrades from Dentsply. They can also now dial into your computer, and they can do that remotely so that they can diagnose and fix a problem really quite quickly. So because technology has come on so much, if you've got a good internet connection and you've got it logged into your central server, etc., they can fix it from remotely. So it actually doesn't so much matter anymore where you live in the world. If you've got a company that's got a kind of global network, then they'll be able to help you.
Yeah, of course. Yeah, that's what I'm looking for. Now is the pause. It's going to be until 2 o'clock. Thank you very much. We would like to discuss a little bit and to see you.
Yeah,
we are very happy. Next year, I hope so that we could organize the Congress on live, not online. Then go live, face to face, and it is you will see on the post here how it looks like when we organize it.
Lovely. Especially
after the Congress, it is special kind of disaster, I could say, but academic type disaster. And I hope so that we will next year we'll see you live and have your some precious lecture.
That would be lovely, and I'll bring some whiskey for you.
Of course. You won't come without whiskey. It's useless. You are coming for Scotland, Absolutely. We are all, I'm Scotland apprentice, of course, and my friend, we are Scotland apprentice, so we have to qualify to be a Scottish guys. I have a lot of friends who are Scottish, so they made me a Scotch apprentice to buy some kilt or something.
Lovely.
It's very expensive for us, of course, but we want really kilts, not for the tourists. It's
lovely.
Yes, so that will be for the next year. I hope so. We could go to Scotland, even to see you. If
Yes,
there's
you're
Congress, if you like
you're
us.
always welcome. You're always welcome.
Oh, thank you very much. We are very happy. We are happy about this. So thank you very much.
Thank you.
It was nice.
Sorry, I couldn't be there sooner.
No, it's okay.
Thank
Anyway,
you.
it's okay. I was trying to answer your questions
Yeah.
as best I can, of course.
Family
Okay.
first.
Yeah.
Thank you. Okay, bye.
I have to tell to the public, we have a pause until 2:00 p.m. And there will be, after that, will be interesting lecture from Dr. Vikas Gold from India, immediate implants in molar region. It will be in 2:00 p.m. So who is interested, we will be here and listen to the lecture.
Thank you. Bye-bye. Bye.
The things that we've been through, you should understand me like I understand you. Now girl, I know the difference between right and wrong. I ain't gonna do nothing to break up our happy home. So don't get excited when I come home late at night, 'cause we only act like children when we argue, fuss and fight. If you don't know me by now, if you don't know me, you'll never, ever, ever know me. No, you won't. No, you won't. Got our funny moves, honey, I got mine. Woman, you got yours too. Just trust in me like I trust in you. And as long as we've been together, that should be easy to do. Just get yourself together, or we might as well say goodbye. 'Cause What good is a love affair? What good is a love affair? Oh, when you can't see eye to eye. If you don't know me, never, never know me. No, 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 no. If you don't know me, never, ever, never. Hey, hey, hey. If you don't know me, you'll never, ever, never know me. No, you won't. No, 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 no. Da, 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 da. Da, 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 da. Da, 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 da. You will never know me.
Kada vidim reklamu za probiotik, hoću da vidim lepe i nasmijane ljude u njoj. Hoću da ih vidim kako su na poslu, možda rade jogu, neki jašu konja i onda bezbrižno jedu. Onda ih naravno zaboli stomak. Dajte mi jednog lepog glumca kako u apoteci kupuje Flonivin Plus, ali da bude srećan kao da je kupio diplomu. A onda ide animacija u kojoj samo jedna kapsula Flonivina Plus sa sastojcima koje ne znam ni da pročitam, pretvara stomak u mirnu zelenu oazu. Potom opet lepi kome je laknulo. Onda sledi veliko finale. Ruka koja na sto spušta pakovanje Flonivina Plus i neki lepi glas da pročita. Da lakše shvatite sve, pa i ovu reklamu. Flonivin Plus. Tako
Najpouzdaniji trajni estetski ispun. Beautifil 2 je geomer ispun koji u sebi objedinjuje osobine glasionomer cementa i kompozita. Znatno drugačiji, poboljšanih osobina rukovanja, lepo se modeluje, ne lepi za instrument i izvanredno se polira. Druge izvrsne karakteristike: prijem i oslobađanje fluorida, čvrstoća vezivanja, kameleon efekat, prirodno prelamanje svetlosti, odlična rentgen kontrastnost i sjajan estetski rezultat zahvaljujući izbalansiranom rasipanju svetlosti. 8-godišnja klinička studija. Svaka tuba za frontalnu i za bočnu regiju kod dece i odraslih. Trajno otpušta fluorid i pruža efikasnu i delotvornu zaštitu od sekundarnog karijesa. U kombinaciji sa odgovarajućim adhesivnim sistemom Beauty Bond, jednokomponentni 6 ml i FL Bond 2, dvokomponentni 2x5 ml, udvostručeno je preventivno dejstvo i uspostavljena je jaka adhezivna veza. Sadržaj seta: 6 Beautifil 2 tuba A2, A3, A3,5, B2, A3 opaker incizal po 4,5 grama, 1 Dura White kamen FL2, 1 Super Snap Single Kit, gumice za obradu i poliranje, 1 One Gloss Trial Set, 3 gumice i papirni blok. Proizvođač Shofu Japan. Poručite ovaj proizvod u Miko Dentalu po specijalnoj akcijskoj ceni. Hvala na pažnji. Vaša Dana, Miko Dental, Dental Depot.
Open
Super Snap, Mini Kit, set šajbnica za poliranje i završnu obradu. Super Snap diskovi na jednostavan način poliraju i obrađuju kompozite brzo i sigurno. Diskovi različitih veličina i finoće imaju elastične držače koji se time jednostavno montiraju na mandrelu. U sredini diska se ne nalazi metalni centar, stoga ne postoji mogućnost slučajnog oštećenja ili prebojavanja kompozita. Ekstremno tanki diskovi su veoma fleksibilni, savijaju se pod pritiskom, bez pucanja i omogućavaju odličan pristup u aproksimalnu regiju. Super Snap uživa poverenje stomatologa širom sveta i redovno je nagrađeni proizvod od Dental Advisora. Direktno i dugotrajno meko podlaganje proteza adicionim silikonom. Materijal za dugotrajno meko podlaganje na bazi A silikona, hladno polimerizujući za direktno podlaganje ustima. Pouzdano vezivanje za akrilatne proteze. Za ručno mešanje, odnos mešanja 1:1. Biokompatibilan bez mirisa i ukusa. Pogodan za imediatne proteze. Takođe pogodan za aplikacije indirektnom metodom, boja gingiva. Proizvođač Detax Nemačka. Poručite ovaj proizvod u Mikodentalu po specijalnoj akcijskoj ceni. Hvala na pažnji. Vaša Dana, Mikodental Dental Depot.
Little piece in you, a little piece in me will join. Oh, this is not America. Blossoms fail to bloom in season. Promise not to stay too long. Oh, this is not the miracle. Not the miracle. There was a time a little piece in me will joy. Oh, this is not America. Blossoms fail to bloom, season promise not to stay. Oh, this is not the miracle. Blossoms fail to bloom, season promise not to stay. Oh, this is not the miracle. Oh, this could be the biggest sky, and I could have the faintest idea. Little piece of you, the little piece in me will joy. Oh, this is not America. Blossoms fail to bloom season. Promise not to stay too long. Oh, this is not the miracle. Little piece of you, a little piece in me will joy. Oh, this is not America. Blossoms fail to bloom season. Promise not to stay too long. Oh, this is not the miracle. I could have the faintest spirals to the ground. So bloody that tomorrow's clouds, a little piece of you, a little piece in me, die. Oh, this is not the miracle. Could be a bigger sky, and I could have the faintest idea. This is not America. Sha-la-la-la-la, sha-la-la-la-la, sha-la-la-la-la. Little piece of you, the little piece in me will join. Oh, this is not America. Blossoms fail to bloom this season. Promise not to stay too long. Oh, this is not the miracle. Spirals to the ground. So bloody that tomorrow's clouds, a little piece of you, a little piece in me, die. Oh, this is not the miracle. Could be a bigger sky. Little piece of you, a little piece in me will join. Oh, this is not America. Blossoms fail to bloom in season. Promise not to stay too long. Oh, this is not the miracle. Little piece of you, a little piece in me will join. Oh, this is not America. Blossoms fail to bloom in season. Promise not to stay too long. Oh, this is not the miracle. Faintest blossoms fail to bloom this season. Promise not to stay too long. Oh, this is not the miracle.
There was a time, a storm that blew so pure.
For this could be the biggest sky, and I could have the faintest idea.
This is not America. Sha-la-la-la-la, sha-la-la-la-la, sha-la-la-la-la.
This is not America. No, this is not. Snowman melting from the inside. Falcon spirals to the ground. So bloody red, tomorrow's clouds. A little piece of you, a little piece in me. Die. Oh, this is not the miracle.
There was a time, a wind that blew so low.
For this could be a bigger sky, and I could have the faintest idea.
This is not America. Sha-la-la-la-la, sha-la-la-la-la, sha-la-la-la-la. This is not
America, oh,
This is not sha-la-la-la.
this is not America, oh,
This is not sha-la-la-la.
this is not America, oh, this is not. Sha-la-la-la, this is not America.
It was only 1 hour ago. It was all so different then. There's nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. Now there's no one home. I grieve. For you. still loving what's gone. They say life carries on. Carries on and on and on and on. The news that truly shocks is the empty, empty page, while the final rattle rocks. It's empty, empty cage. And I can't handle this. I grieve for you. And you me. Let it out and move on. Missing what's gone. They say life carries on. They say life carries on and on and on. Life carries on in the people I meet. In everyone that's out on the street. In all the dogs and cats. In the flies and rats. In the rot and the rust. In the ashes and the dust. And life carries on and on and on and on. Life carries on and on and on. It's just the car that we ride in, the home we reside in, the face that we hide in, the way we are tied in. And life carries on and on and on and on. Life carries on and on and on. Did I dream this belief, or did I believe this dream? Now I can find relief. I
Hi, Greetings here from India. This is Dr. Vikas Gaud speaking on immediate implants. First of all, I would congratulate the Serbian Association of Implantology for having organized this Congress, and thanks a lot, Professor Zoran, for having invited me for this Congress. Let me share with you on our topic today. Immediate implants in the molar region. Well, immediate implants is not just immediate extraction and placement of implants in the socket, but also immediate implant loading in the molar region. So is that really possible, or is it a myth or a reality? Let's find out. The Serbian Association of Implantology, along with the European Dental Association of Implantology, 2022. This is me. I'm founder, president, School of Dental Implants, where we run our private practice and also a training institute. My prayers of hope, strength, and faith for the war and the people in the countries where there is war in our neighboring country. I just hope that by this time this presentation is aired, hopefully this war comes to an end. Well, I come from a small city in the south of India called Hyderabad. Just let me show you where and what we do. So this is also called the City of Pearls, Hyderabad. It's the most fastest developing city here in India. That's a little bit about our infrastructure that's happening. This is 500-year-old history of this place, Hyderabad. And it's also ranked the best city to live in. There are currently around 7 million people living in the city and increasing every day. Well, immediate implants in the molar region, immediate implants versus delayed implants, immediate implants about patient demands versus delayed implants where we get predictable results. Well, we've been doing immediate implants in the anterior aesthetic region for a long time. Immediate implants in the anterior aesthetic region have been pretty successful. We extract the tooth, place the implant, and also provide a provisional immediately, like here, how you see a flapless atraumatic extraction done, implant placed, and grafting into the jumping distance, and an immediate provisional, a CAD/CAM mill provisional provided. This CAD/CAM mill provisional goes and sits into the implant socket, and that gives us the soft tissue aesthetics. And soon we have a beautiful white and pink, which mimics the adjacent tooth. So this is what we can do. And once a broken tooth is there, even in the closest photograph, this young girl who met with an accident just before her wedding, where we have done immediate implants and fixed her teeth. And even in her closest pictures on her special day, we can't make out which are the teeth which have been implanted and which are the teeth which have been which are actually her natural teeth. So this is the kind of aesthetics and state of the art of work that we are able to achieve today. Coming to the molar region, in a conventional procedure, atraumatic extraction, engagement of the radicular bone, use of short and stout implants into this region, and we have had more than 7 years of success. So we have been able to place immediate extraction and implants, and even over a 7-year period, these delayed loading protocols have shown to us extremely good results. Well, here is another case where it is delayed implant placement into grafted bone, but immediate placement of immediate implant loading. So a molar extraction grafted done more than 10 to 12 months prior. The patient came in a little late after more than a year because of her own engagements, and then we were able to place the implant into the socket. Here a long 13mm implant was placed, and then we were able to do immediate implant loading because of the kind of primary stability that we were able to achieve in this region. So this is implant placement done right in the direction where we want, good primary stability, early implant loading or almost immediate implant loading done in this case in the maxilla. Well, we have also been doing immediate loading of full mouth cases, all on 4, all on 6, where tilted implants have been used and a short arch and full mouth rehabilitations have been possible. Normally, these cases after immediate implant placements, over a period of time, we give definitive prosthesis, normally around 4 to 6 months time, we give them a definitive prosthesis. Similar in this case where a Malo bridge, individualized Malo bridge has been given, or whatever form of a hybrid prosthesis or a full mouth cement retained prosthesis, which is possible. Well, coming to the posterior region, the posterior challenge for molars is for immediate implant placement and immediate implant loading, as these are multi-rooted teeth. So our primary challenge lies is where is that we're going to go in and place our implants. Number 2 is the position and direction of implants. Where are we going to use the position and where is the direction of implants that is going to happen? Number 3 is non-axial loading of the prosthesis, where we don't want any kind of cantilevers to fall on the prosthesis. Engaging the walls of the socket. So if we are able to engage the walls of the socket, whether we are able to engage the walls of the socket correctly, so that we get the kind of primary stability that we want. These are some of the challenges that we face when we place implants in the molar region. Well, normally what happens while we drill, when we extract the tooth and when we go into drill and place, it normally our drill slips into one of the sockets and primarily, we either put it on the mesial socket or the distal socket. So slipping of the osteotomy drills into one of the roots, like how you can see in this case, that the osteotomy, the one of the sockets here in the mesial root where the implant has been placed. Well, posterior molar extraction, immediate extraction and immediate implant loading. Is it a myth or a reality? So in the molar region, when we do these kind of extraction and these cases, so these cases, the kind of protocol that we follow here is that atraumatic extraction, flapless surgery, and immediate implant placement. So we do an atraumatic extraction, do a flapless surgery, and then we do an immediate implant placement in this case, the way you can see it here. So that is how we do. And early implant loading is when there is good soft tissue healing and emergence profile. So early implant loading is 2 weeks. So we immediately do the implants and then we wait before the final prosthesis or a provisional prosthesis is done. Less than 2 weeks, the prosthesis is given. So this is early implant loading. This can be with the definitive prosthesis or with a provisional prosthesis. Here in our study, a total of 142 wide diameter implants done between 2012 to 2020, 60 of them in the maxilla and 82 in the mandible, age group between 23 and 69 years in 124 individuals, mostly single teeth missing between 2012 to 2022. So these are the cases and these are the way the implants have been placed. The gray ones are the 7mm implants and the orange ones are the 6mm implants, and the blue ones are the 5.5mm implants. So wide diameter or extra wide diameter are the ones which are beyond the regular conventional 5mm diameter implants that have been taken into this study. So a total of 82 cases in the mandible and 62 implants in the maxilla were taken in the study. 52 of them male and 67 female patients were included in this study. Well, various implant companies that have been part of the study are Zyve, CMI, Tough, Dentium, Blue Sky, and Adin. All of them between the range of 5.5 to 7 millimeters diameters. So these are the various companies that have been included in the study. Cortex, Saturn implants, where the diameter, the collar diameter is 3.8 and 4.2. But when you actually look at the diameter of the wings of this kind of design, this is more than 6 millimeters. So this has also been included in the study, which has been indicated for immediate implant load in the posterior region. Well, these are various, these are our offices that we work or operate from. Well, prerequisites for immediate implant placement. No breach in the socket walls after extraction. So obviously we don't want any breach in the socket walls once we extract. So we want to extract it as atraumatically as possible. Intact bony housing, especially in the buccal plate. Extraction socket free of any kind of pathology. Sufficient bone volume apical to the socket to ensure primary stability. We're looking at least 4 to 5 millimeters of socket beyond the apex for us to go ahead for this protocol. Well, coming to this protocol, immediate extraction, implant placement, and immediate implant loading. So the first step, the osteotomy is done even prior to extraction. So this way, you know, when we do the osteotomy even prior to extraction, the roots of the teeth, they actually act as the guide for us to go ahead for the osteotomy. So we either take between the two roots or the center of the root where we actually want our drill to go. And that is how we go ahead and do our drilling sequence. One important thing is, since we're doing the osteotomy, if we try to luxate the tooth prior, and we know for sure that we will be able to extract the tooth with ease after the osteotomy is done. We don't want to be held in a situation where we do the osteotomy and then we have difficulty removing these pieces. So this is how we do the osteotomy through the tooth, the way we saw it. And that is how we do the osteotomy between the two roots. And we know for sure, and these two roots also act as guide for us so that we are able to do the osteotomy right in the center. The advantages when we do this kind of osteotomy is the parallelism, or the direction that we want to place our implants is the where exactly the biomechanical direction that we want. It is parallel to the adjacent tooth, and also the direction for the opposing tooth. It's exactly in the direction that we need to go for the opposing tooth, and for the biomechanics, and also for the opposing tooth where the pressure or the point that is going to come in. So the implant positioning and direction is perfect in the line of occlusion and parallel to the adjacent. Well, after this step is when we do the extraction. So the atraumatic extraction is done after the osteotomy is done. Complete debridement of the socket, both with physically and chemically. We try to debride the socket of any kind of pathology that may arise or that may be there. Step 3 is placement of an extra wide implant or an ultra wide implant. An implant with a diameter of more than 5 millimeters is what we have defined in the study as an ultra wide implant. Since most companies have 5 millimeter as their regular platform or their widest implant. So anything beyond 5 millimeters we have been including into our study, and our current study is more on extra wide implants or implants above 6 millimeter and above. So here we go ahead with the wide diameter implants. Sometimes maybe the last osteotomy drill of the 5 millimeter drill is done after extraction, and then we go ahead and place our implant into the socket. When we normally place our implant into the socket at this time, we get extremely good primary stability. So we are able to place a short implant and also get very good primary stability. It engages both the buccal and lingual walls, and we are able to place it subcrestally to the existing walls. And this gives us very good primary stability because it is engaging both the lingual and the buccal cortical plates. So these are some of the benefits of ultra-wide implants, fits multi-rooted molar sockets and allows for immediate placement following extraction. Maximizes bone preservation, minimizes the need for bone grafting. Though in most of our cases we do grafting, but the amount of graft material that is required to close up these sockets is minimized when we use this ultra-wide implants. This ultra-wide implant also allows for increased engagement of molar socket walls and provides better stress distribution under high occlusal loads, avoids adjacent tooth roots, reduces the treatment time, ability to use standard surgical protocols and instrumentation with minimal additions. There was a time when for a single molar tooth, if it is beyond 14 millimeters, it was advocated that we do 2 narrow platform implants. While when we do with a very wide or an ultra wide implant, we could avoid giving that kind of 2 narrow implants, and just a single wide implant can be used for this protocol. Another advantage when we increase the width is for every 1 millimeter increase in the width of the implant, there is a 33% increase in functional surface area. So between a 4 millimeter diameter implant to a 7 millimeter diameter implant, the functional surface almost doubles. That means the same length of a 4 millimeter implant to that of a 7 millimeter diameter implant, the functional surface area doubles. So we have much more surface area to hold on to this implant. Subcrestal implant placement, wherein most of the buccal and lingual walls are being engaged. So 2 to 3 millimeters of subcrestally, when we are able to place it, it actually goes and engages both the buccal and the lingual walls, not just the apical region, and giving us 3-dimensionally, not just the accuracy of the implant, but also the primary stability. Step 5 is complete debridement and grafting in the socket space left after implant placement. So before we actually place our implant, we debride the socket. And once the implant is placed, we do grafting into the adjacent remaining areas so that that area is filled with a slow resorbing graft material. And then we go ahead for the closure of these space. So step 6 involves placement of an extra wide healing abutment or an anatomic abutment. So here in this case, you can see that there is a extra wide healing abutment being placed that helps to achieve a primary soft tissue closure, especially in flapless situations where we don't actually reflect the flap so much. We want to use a flapless situation. So a couple of sutures needed on both sides proximally to get us the primary closure. Anatomic stock abutments. These anatomic preformed stock abutments that are available that have been milled prior, these are being used as a one-time abutment protocol where these stock abutments are being placed into the on top of the implant as a one-time abutment, and we take an impression of this stock abutment to give the final prosthesis or the provisional prosthesis. So our idea is to use the stock abutments once we know what is the primary stability, and we also know the ISQ values for choosing whether we're going to do a delayed implant placement loading or an immediate implant loading or an early implant loading. So delayed implant loading, if we have less than 50 Newton torque and no soft tissue closure, then we are waiting for at least 2 to 3 months, that is around 8 to 12 weeks before we go in for loading. Most of our cases that have been done in the study are early loading where more than 50 Newton torque, good ISQ values, or more than 60, but sometimes not sufficient soft tissue healing has occurred. So in these cases, either a very wide healing abutment or an actual anatomic abutment has been placed, and then soft tissue has been closed with sutures, and we have waited for the soft tissue closure, after which we have gone ahead to give the patient a provisional. Immediate implant loading is more than 50 Newton torque and good soft tissue closure along with ISQ values of more than 60. that is a time when we have gone in and placed immediate implant loading, whether with a provisional or with a definitive prosthesis. Biomechanical advantages of a wide diameter implant: greater force conditions, we reduce the cantilevers, parafunctions are reduced, greater crown root ratio, and our angled forces are again reduced. So if you actually look at our tooth anatomy itself, if you look at our tooth anatomy, whether it's a premolar or a molar, the crown ratio or the crown width is close to 10 millimeters. So between 7 to 10 millimeters from the cervix to the crown region around, especially in the molar regions, if you look at it, it's around 8 to 10 millimeters for the molar regions, whether it's the maxilla or the mandible. So 10 is the mesodistal width and 8 is the buccolingual width that we look at. So when we take a 6 and a 7 millimeter, biomechanically, we are able to support that tooth to a large extent, so without any kind of cantilevers or non-axial forces falling on it. So use of a stock anatomic abutment. So these are pre-milled anatomic abutments that are available in the market for the molars, which we use as a one-time abutment. This one-time abutment before soft tissue healing or after soft tissue healing is placed on the fixture, and this is being used as one time, which is not going to be changed. And the next impression stage would be we directly take an impression of this anatomic abutment and send it to the lab. Either we take a digital impression or analog impression of this abutment directly in the mouth and send it. When we take this anatomic abutment out and when we see, we have extremely good soft tissue healing, like how you can see in this case, we have extremely good soft tissue healing. So the emergence profile and the aesthetics from a soft tissue point of view is extremely good when these anatomic abutments are being used. Less screw loosening and less fracture has also been reported when we use a one-time abutment. So implant abutment level impression, a digital or an analog impression is being taken. These abutments are not removed to place either the scan bodies or impression posts. So this abutment, only sometimes the margin is prepared of these abutments and then they are being sent to the lab to make definitive prosthesis the way we want. We have used in our study regular stock abutments, wide diameter regular stock abutments, and we have also used an anatomic stock abutment, like how you can see on your left and on your right. So once the ninth step involves, once this abutment and an impression is taken, an immediate provisional crown in PMMA out of occlusal contacts, if it's immediate loading or early loading, and sometimes a definitive prosthesis which is touching has been also used in this protocol. So a wide diameter fixture helps in ability to use compatible prosthetic components by platform switching. So most of these implant designs have had a platform switch where we are able to do an implant placement, the abutment, and that has been given, like how you can see in the pictures here. So the definitive prosthesis being given between 2 to 4 weeks. So in this case, you can see that between 2 to 4 weeks, an actual definitive prosthesis has been delivered to the patient once the soft tissue healing has occurred, and this has been remained that way. So some of the precautions that the patient needs to understand once this kind of a protocol is being used, strict guidelines to follow for soft diet and mastication for at least 8 to 12 weeks following the loading. So at least another 2 to 3 months, they have been advised soft diet, especially on that side, and to follow up with us every couple of weeks just to know how the implant and how the tooth is and the prosthesis is doing. So a total of 142 implants done with immediate implant placement and extraction sockets, and 91 of them were loaded within 2 to 4 weeks and after soft tissue healing. And 24 of them were loaded immediately with a provisional. So this is our graph showing immediate loading and immediate extraction and early implant loading and immediate extraction and delayed implant loading. So mean bone loss after 2 years between immediate implant loading, early implant loading, and delayed implant showed no significant statistical difference of less than 1 millimeter. Sorry, less than 0.1 millimeters if you look at most of them. So in fact, early implant loading had a mean bone loss level of 1.12 compared to that of immediate implant loading of 1.06, while that of delayed implant loading was still at 1 millimeter. So this is the bone loss levels. So as I already told you, the criteria for choosing immediately implant loading or delayed implant loading dependent on the soft tissue and the ISP values that we achieved after placement of the implants. So of the 142 implants, extraction and loading done at various times, 64% of them have been done as immediate extraction and early implant loading, that is 2 to 4 weeks, while 17% have been done as immediate extraction and immediate implant loading before 7 days of time, and immediate extraction and delayed implant loading in 19% of the cases. So most of these cases have been early implant loading after soft tissue healing with definitive prosthesis. The success rate of this study has showed that there is only 5% failure, which is in fact in line with most of our studies with delayed implant loading following the regular Brannemark protocol. Immediate extraction and immediate implant loading in single molar sockets, total 26 implants following this. So here we are comparing with immediate extraction and immediate implant loading in the molar sockets. That means the few implants of only 26 implants were immediately extraction, implant placement, and also loading was done with the provisional prosthesis. So we found that there was among them 74% of them were immediate implants with early implant loading and only 4% failure, while compared to that of immediate extraction and immediate implant loading, total implants followed with immediate implant loading in the mandible was 81% compared to that of the maxilla, which was just 19%. Benefits of this protocol. Well, our patients come to us for an immediate restoration. Our patients come to us for a tooth, and here we are able to give them an immediate restoration. Extremely good aesthetics because of the soft tissue profile that we are able to do. Preservation of bone volume compared to our other delayed loading protocols or delayed implant placement protocols. Our preservation of bone is much higher in these protocols. Reduced chair side time. Once our immediate during the surgical phase itself, once the one-time abutment is placed, our chairside time is practically negligible when the patient comes next. And extremely good patient satisfaction that we have found with this protocol. So these are some of the great benefits that we found. Some of the challenges that we faced with this protocol are sometimes it becomes a little challenging to get good primary stability soon after placement of these implants. Number two is sometimes graft material can be embedded into the soft tissue when we remove it for the second stage. We see that small particles of graft that can be embedded. Number three is unpredictable buccal gingival level. Sometimes after the anatomic abutment has been placed, after a few months or after a year or so, we see that the buccal margin of this crown could be exposed. Because these are the posterior regions, most of the patients don't complain to us, but this becomes a challenge when we look at them and we want to document these cases. Prosthetically, we see that sometimes the provisional could break, which is normal with most PMMA or provisional crowns. Prosthetic screw loosening during this healing phase is another thing that could probably happen. In a few cases, we have seen that the prosthetic screw loosening that could happen as this. Following this protocol, we can say that immediate implant loading in the immediate implant placement and immediate implant loading in the posterior extraction socket is a viable option following the strict protocols and precautions after the procedure is followed. Use of ultra-wide implant. These are some of the important things. Use of an ultra-wide implant. Use of anatomic stock abutment with a stable conical connection. If you are able to achieve primary stability of more than 50 Newton torque, we can go for immediate or early implant loading. Giving an immediate provisional or an immediate definitive prosthesis is possible if we are able to achieve a good primary stability and a good primary closure. Following this protocol, we can say that immediate implant loading and implants in the extraction socket in the posteriors can be used as a viable option, following the strict protocols and precautions after the procedure. However, from the available data, some more studies are required and needed to know the success of this procedure. Probably multicentric studies following this protocol could be required. Here, a more active design would be more suitable that suits the anatomy of the roots, that has a stable conical connection with platform switch is recommended, so that you can go subcrestally having a platform switch and also implant design that matches with the posterior anatomy, which is very active in nature. Well, these are a few of the recommendations that me and my team have found to go ahead for this protocol. More active design, active fixture design that suits the anatomy of the roots, that has a stable conical connection with platform switch is recommended for this protocol. Prosthetically, anatomic stock abutments, which can be pre-milled and kept with us with various gingival heights and dimension, that has a strong and stable conical connection with platform switch. So these are the recommendations that me and my team have made so that we can go ahead for this protocol. Well, friends, I hope this can be an eye-opener, and let's not make best something that has worked with us for a long time an enemy for the better. So let us keep an open mind and let us see that once we go ahead for these kind of protocols, and when we try out these protocols, let's not make something that has proven to us for 10 years become an enemy for something that we can do faster and better. Thank you all. That's from me, and I was hoping that we would have more of these physical conferences and physical conference where we can meet not just for these congresses and lectures, but also for the fun parties, fun after parties that we have. Thank you. That's from me here in Hyderabad and in India. So any questions that may arise, we can take it up during the question hour.
Dr. Vikas, thank you very much. I can see you. It's nice time down there. You are down under Equator. You have summer with the early time here with fog, and I believe you know that you've been in England for studying, I think so. So you know. So I hope so that you enjoy a good time down there in your country.
Yes, it's
of course. There is some questions here, and you can see, if you can see here, I will read it if you don't just see some. Dr.
Right.
Dejan, how long does it take from extraction to prosthetics loading? And do you differentiate between maxilla and mandibula? Is there difference between maxilla and mandibula, upper and lower jaw?
Right. Yes. So during the lecture, I said based on the kind of primary stability that we get at the time of implant placement. So if I am able to get ISQ values of about 60, and I feel that there is soft tissue which is thick and the gingival biotype is a good thick biotype, then I would want to go for an immediate implant loading. While in case I still get good primary stability and ISQ values, but I feel that the graft, I am not able to get good primary closure, and soft tissue closure is not possible even with a large abutment. Then I wait for 2 weeks to get a little bit of soft tissue closure, and then we give a provisional sometimes, not a definitive process, but a provisional
and I also explained about the occlusal scheme. So in the occlusal scheme, we keep it around 25 to 30 microns. Around 29 microns is what is recommended. Around 29 microns, because all of these prostheses or these crowns are CAD/CAM milled. So because these are all CAD/CAM milled, we are able to keep the amount of occlusal scheme to exactly in the CAD/CAM mill to that much under occlusion. And these are delivered. And so far, it is a short time to decide how well this protocol works. But yes, so far it is doing well for the last 6-7 years of time that I and my team have been working, and the results are very promising.
Oh, yes, thank you. Second
And
question. Yes.
yeah, sorry.
Sorry.
In terms of between the maxilla to the mandible, yes. As you can see from my statistics that there are more number of cases done in the mandible than in the maxilla. Obviously, you could understand because of the bone type. In the maxilla, normally the kind of bone that we have is much more softer, and you may not get the kind of primary stability that we would want. So compared to that, in the mandible, most of the time we get good primary stability, and we are able to do it. So at the moment, there could be a bias that, there are very few cases of the maxilla than compared to the mandible.
If we are talking about its immediate loading in the mandible, could we say that it is good to have actually bicortical stabilization? That's why that will affect both sides of the cortical lamella, and this is, of course, in that case, is stability. You need fat and short implant in the same time,
Not
like that.
And short, but see here, my cortical engagement is more on the buccal and lingual plates, not so much below the root level. So I do below the root level, but sometimes the anatomic constraints, we have the nerve, we have the sinus in the posterior. So because of that anatomic constraints, it becomes challenging to get a bicortical engagement. So here I have to engage the buccal and lingual plates.
Yes, in the mandible, of course, it's look like it's a bicortical something. Placing bicorticals with some sharp spears or something to enter the cortical lamella inside, so you have immediate, very good stability. Okay, there's a Dr. Marco was asking, what force in nanometers do you apply during immediate implantation? What force?
Right. So the force here, I told you, normally when the torque being applied, it goes to about 60 Newton torque, but I depend on reverse torque and also on the ISQ values to go for the immediate loading. So I take the when I'm torquing in, it should be 65. So a lot of times my implant machine, the physio dispenser, gives me only up to 80, but sometimes we may have to still do hand ratcheting, which goes beyond. So also an important point to consider here is an implant design which has an internal connection that doesn't break above this torque levels. So that is also important. So far I've had good, because these are wide implants, they normally don't flower, and they are being pretty good when I'm been talking about 65, 70 Newton torque. And sometimes hand torquing, so it is above. And when we are doing reverse torquing, it comes to 65 to 80 Newton torque, so which is pretty good.
Thank you. I'm sorry. Another question, Dr. Marco. What type of bone graft are you using?
Right.
And prefer? What kind of?
Right. So here I prefer a slow resorbing bone graft, because ideally as such, my primary stability is coming from the bicortical engagement. So I am using a slow resorbing graft. It could be bio-os or mineralized bone, or a combination of beta TCP and hydroxyapatite. where, you know, my natural bone goes and engages into this mineralized bone. So that is the one that I have preference. And so far it's been working well for me.
No, nice, of course. I use the same. My experience is like BIOS or something like that. Excuse me. And there is no more question. I would like to ask you some tricky question, but as you can see, this is friendly meeting, and generally this is the friendly meeting. In the books about implantology, the failure is 25% on immediate loading, generally. It's 25%. Long ago, when I was doing some immediate loading and using a monophasic with some selding around, you know, that fixing like this, the logic mine I was doing to protect myself, but you placed 8, 9 implants where you have bone, you lose 3, on the others you can make it, you move it and you place definitive prosthetic work on this. So Soraya, I was not doing that. I'm just telling you that the book side, and this is a 25%. But it is old. It is old. New techniques and using implants, and implants are different. So you can say this is written in the book, but it's not. Tell me something else. There is a lot of talking about density of the bone. The same, this. So must be something individual to this patient. My experience is completely for density or something. Friends had to go to America, has bad low teeth. Could you make it 10 days teeth? Yes, I can, but I don't know what will happen after years. Yeah, one was very hard for drilling, and I was doing, and it was very hard. The other was very, very soft bone. What happened? This guy was very happy. He said, I'm good, I have hard bone. This was lousy, I'm sorry, it's soft bone. What happened? After 2 years, this with hard was everything gone out, and this soft bone stays even nowadays. So there is in this what we are talking, we need something to catch what is, by your opinion, that I can catch. What is this? This is hard bone, this is soft. Hard bone left, implants, soft bone stays everything. Same implants, same everything. Okay, individual. This is a patient individual. But what do you think is the point that I can catch what I can do when I have a patient who wants some immediate loading? What's the trick?
So for
My
immediate
experience.
loading, for right. So I think
It's
if
a
you're
difficult
talking about
question. I'm sorry. It's a difficult question. I'm sorry.
Yeah, I know. I
It's
know.
friendly.
It is
It's very, very friendly.
No, I understand. So as from my experience, you know, so for full mouth cases, I am doing tilted implants and using multi-unit abutments and giving them. So we normally give immediate provisional, screw retained immediate provisional. So one thing I try to see is all my implant where I'm doing a full mouth immediate load have torque levels about 35 to 40 Newton torque. So this is for full mouth cases, full arch upper or full arch lower I am talking about. So there I try to see that all my implants. So just in case I don't get, I'm doing all on 5, all on 6, or all on 8. If I don't get 1 or 2 implant, which I don't get primary stability, I only use the other 4, which I'm getting the primary stability, and use the multi-unit there. So yes, having good bone is very important. And I always tell my patient, there is plan B. You know, I am trying to do my best to give you immediate loading, but just in case it is not possible, because of the bone, the way the condition, the pathology around it, local conditions, general conditions, my surgical hand, if anything goes, there is a time period that you may have to wait, and I will try to give you whatever best removable processes in the time being. So though it is immediate loading protocol, I try to give them, and most of my cases, almost 80% of them are successful. I think the bone around it, the local factors, they dictate, however good your surgeon you are, the local bone and the bicortical stability, they dictate whether you can do immediate loading or not. So from my point, every case is different, and however best you do. So sometimes in those cases, a small trick like the way you asked is if it is the maxilla, I know it is soft bone when I do the first drill. So I under drill the implant socket or the osteotomy, and I put a wider diameter implant. So under drilling, trying to get primary stability. In a few cases, I have used densa burrs for increasing the bone, mineralized bone around it in the maxilla, so that you get much more primary stability. So some small techniques where you can try to get more primary stability is what I do. And in the posterior mandible, especially like I said, following this protocol, I've been very, almost more than 90% of the cases, I've been able to get very good primary stability. I'm talking about my presentation of single tooth in the posterior mandible or in the posterior maxilla in the molar region. So since we've been doing this in the anterior region, I want to try the region, and it's being used also. PMMA as immediate provisionals. I've used PEEK materials and HPPA, which is again like a resin mixed, but as a definitive prosthesis. These have been used and they have been in function. These PEEK materials and all have been in function for now almost 6 years, 5 years and 6 years. And so far they're doing good.
Thank you very much. I thank you.
Thank you.
In our name, in our colleagues online, it was happy. Maybe for the next year, we're going to invite you. It is a long trip for you, but it's reachable. It's reachable. Believe me, I would like to invite you to next year to our Congress. Thank you very much. Thank you very much.
Thank you. Thanks for the invite and thanks for the lovely time. Thank you.
Thank you. I'm calling Professor Stevo Matijevic from Serbia. He has in 15 hours and 3 o'clock p.m. He has lecture. This is specific lecture. I want to warn all the colleagues. By some kind of law, if we have international congress, specifically this is dentistry, stomatology, and these things, we have to have at least one lecture or presentation from general medicine. So this will be something about antibiotics, probiotics, and colitis, and this. And this is, I want to inform you that it will be the general medicine, because we are obligated to have for the international congress. It's 15 hours or 3 p.m. It's going to be start his lecture. Thank you.
Nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. No one home. I what's gone. They say life carries on. Carries on and on and on and on. The news that truly shocks is the empty, empty page, while the final rattle rocks. It's empty, empty cage. And I can't handle this. I grieve for you. And you let it out and move on. Missing what's gone. They say life carries on. They say life carries on and on and on. Life carries on in the people I meet. In everyone that's out on the street. In all the dogs and cats. In the flies and rats. In the rot and the rust. In the ashes and the dust. And life carries on and on and on and on. Life carries on and on and on. It's just the car that we ride in, the home we reside in, the face that we hide in, the way we are tied in. And life carries on and on and on and on. Life carries on and on and on. Did I dream this belief, or did I believe this dream? Now I can find relief. I grieve. everything's all so different. There's nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. Now there's no one home. I agree. For you, you It's so hard to move on. Still loving what's gone. They say life carries on. Carries on and on and on and on. The news that truly shocks is the empty, empty page, while the final rattle rocks. It's empty, empty cage. And I can't handle this. I'd read for you. And you let it out and move on. Missing what's gone. They say life carries on. They say life carries on and on and on.
Snimanje pa ćemo da eventualno ponovimo ako bude trebalo. Evo, to je to. Kad god ste spremni, samo recite. Ja ću zatvoriti vrata da ne bude buka.
Držim. Poštovane koleginice i kolege, interesovanje za probiotike već dugi niz godina je u fokusu stručne javnosti. Mnogi pozitivni efekti koji probiotici imaju na ljudsko telo i na ljudski organizam dokazani su kroz brojne eksperimentalne i kliničke studije. Stoga, probiotici zauzimaju značajno mesto kako u promociji zdravlja, prevenciji različitih bolesti, tako i terapiji određenih simptoma, prvenstveno gastrointestinalnog trakta. Crevna flora jeste jedan skup, ili crevna mikrobiota, jeste jedan skup mikroorganizama koji žive u našem digestivnom traktu i koji su potpuno određeni našim DNK. Tu jedinstvenu kombinaciju mikroorganizama dobijamo odmah po rođenju, na porođaju od majke, gde se ona tokom života neznatno menja u zavisnosti od faktora sredine, od načina života i načina ishrane. Inače, crevnu floru digestivnog trakta ljudskog organizma čini u proseku između 300 i 500 različitih bakterija, a procenjuje se da ih ima negde oko 100 triliona. Iz samog tog broja proističe i značaj crevne mikroflore i crevne mikrobiote koje ona ima po naše zdravlje. Obično pri samom pomenu na bakterije imamo neki negativan predznak i ubeđenje kao potencijalnim napadačima i izazivačima infekcije. To može da bude samo delimično tačno, jer u našem organizmu obitavaju i žive i dobre, korisne bakterije i taj njihov odnos i prevlast dobrih bakterija u odnosu na loše bakterije, a procenjuje se da su dobre bakterije zastupljene sa nekih 85% u odnosu na 15% zastupljenosti loših bakterija, jeste jedan od najvažnijih preduslova za zdravlje digestivnog trakta, ali i za zdravlje našeg organizma u celini. Inače, crevna mikroflora obavlja brojne značajne funkcije u našem organizmu. Ona potpomaže varenje, reguliše telesnu težinu, proizvodi određene vitamine, posebno vitamin K i neke vitamine iz B grupe. Takođe, u toku fermentacije hrane stvaraju se kratkolankčane masti, butirati, propionati i acetati, koji jačaju zid creva i na taj način sprečavaju prodor različitih štetnih supstanci i patogenih bakterija u naš organizam. Jer sa fiziološke strane gledano, prodor kroz crevnu barijeru jeste abnormalni događaj, a baš na takav način izvesne bakterije ostvaruju svoj patogeni efekat, kao primer radi salmonele ili šigele. Takođe, crevna flora ima izrazitu antibakterijsku funkciju, lučeći određene baktericine i na kraju ima izrazit uticaj na stimulaciju i jačanje našeg imunog sistema. Jer, kako se napominje, u gastrointestinalnom traktu se nalazi preko 70% svih naših imunih ćelija. Inače, intestinalni trakt i centralni nervni sistem su u stalnoj jednoj međusobnoj komunikaciji i interakciji. I ta veza jeste dvosmerna. Primarno se odvija preko vegetativnog nervnog sistema i uz pomoć i funkcionisanje endokrinog sistema, odnosno stvaranje takozvanih hormona digestivnog trakta, preko jedne poznate fiziološke osobine hipotalamus, hipofiza, endokrine žlezde. Međutim, tom kompleksnom sistemu jeste pridodat i još jedan jako bitan član, a to je crevna flora. U čemu je njen značaj? Znači, brojni molekuli koje stvaraju bakterije tokom fermentacije, kao i sastavni delovi samih bakterija, ne predstavljaju ništa drugo nego neurotransmitere koji stalno šalju informacije centralnom nervnom sistemu kolika nam opasnost preti od infekcije i da li treba da se pokreće naš odbrambeni mehanizam. Normalna fiziološka flora, odnosno mikrobiota našeg organizma, bez obzira bila ona interstinalna ili recimo orofaringijalna, ispoljava jedan snažan antagonizam prema patogenim bakterijama u tranzitu, ali takođe i prema patogenim bakterijama koje čine normalnu fiziološku floru i na taj način ih stalno drži pod kontrolom i u ravnoteži. Međutim, kako živimo u ovom savremenom svetu, savremeni način života, prepun stresa, različitih prirodatih bolesti, brojnih zapaljenskih stanja, česta upotreba lekova, posebno antibiotika, oštećuje crevni trakt, dovodi do poremećaja crevne flore i na taj način dovodi do jednog stanja koje se u stručnim krugovima naziva interstitialna disbioza. Značaj ove disbioze nije samo u tome da česte i ponovljena akutna stanja vremenom mogu dovesti do hroničnih upala, tipa ulceroznog kolitisa, Kronove bolesti. Taj značaj disbioze jeste daleko veći i širi, jer njeno postojanje ima i tekakve reperkusije na druge organe i organske sisteme, dovodeći do izvesnih kožnih oboljenja, hematoloških oboljenja, kardiovaskularnih bolesti, metaboličkih bolesti i izvesnih autoimunih oboljenja. U prilog tome najbolje govori citat ruskog istraživača Mečnikova, koji kaže da većina bolesti započinju u digestivnom traktu kada dobre bakterije nisu sposobne da kontrolišu loše. I šta tada radimo u tim situacijama? U pomoć, između ostalog, zovemo i probiotike. Neka najšira definicija probiotika bi bila da su to živi mikroorganizmi koji kada se unesu u naš organizam izazivaju povoljne efekte na zdravlje domaćina. Međutim, u stručnim krugovima najčešće i najprihvatljivija definicija jeste ona koju su dali Scheisenmeier i De Vrese, da su probiotici proizvodi koji sadrže žive, tačno definisane mikroorganizme, u dovoljnom broju sposobne da menjaju mikrofloru implantacijom ili kolonizacijom u određenom delu ljudskog organizma i na taj način ispoljavaju povoljne efekte na zdravlje ljudi. Da bi neki preparat bio označen kao probiotik, on mora da zadovolji brojne kriterijume. Između ostalog, da ne trpi genetske varijacije, da pokazuje stabilnost u formi i obliku kome će se naći u upotrebi, da ne dolazi do gubitka senzornih karakteristika i kvaliteta proizvoda, da pokazuje sposobnost za preživljavanje u gastrointestinalnom ekološkom sistemu, da ne izaziva neželjene efekte, da pokazuje inhibitorni efekat na patogene bakterije, da pokazuje sposobnost inaktivacije prokancerogenih ćelija i takođe da ima pozitivan uticaj na naš imunski sistem. Danas postoje dve velike glavne grupe probiotika. Jedna grupa jeste na bazi dobrih bakterija i druga grupa jeste na bazi gljivica. Što se tiče bakterijskih probiotika, uglavnom se radi o probiotskim bakterijama na bazi laktobacilusa i bifidobakterija. I sojevi laktobacilusa i bifidobakterija jesu gram pozitivne štapićaste bakterije koje ne stvaraju spore. Laktobacilusi se uglavnom nalaze u tankom crevu, aerotolerantni su ili anerobni, dok bifidobakterije naseljavaju debelo crevo i uglavnom su anerobne. I jedna i druga grupa bakterija pripadaju takozvanim grupama mlečne kiseline. Na koji način oni ostvaruju svoje dejstvo? Primarni način delovanja probiotskih bakterija jeste da svojom brojnošću vrše kolonizaciju interstitialnog trakta i na taj način oni čine direktnu konkurenciju za hranu patogenim mikroorganizmima. Takođe, tom istom kolonizacijom i brojnošću oni ojačavaju crevnu barijeru, odnosno crevni zrid, i sprečavaju prodiranje patogenih bakterija u naš organizam. Lučeći mlečnu kiselinu, redukuju pH, naročito debelog creva, i na taj način favorizuju rast probiotskih mikroorganizama. Takođe, probiotske bakterije imaju antibakterijski efekat, lučeći organske kiseline, baktericine, vodonik peroksid, te na taj način one direktno eliminišu brojne gram pozitivne i gram negativne patogene bakterije s jedne strane, a s druge strane inhibiraju njihov metabolizam, kao i inhibiraju proizvodnju različitih njihovih toksina. I još jedna važna uloga probiotskih bakterija jeste što utiču na stimulaciju i jačanje našeg imunog sistema i humoralnog kroz lučenje imunoglobulina A, ali i celularno kroz stimulaciju T limfocita. Kada ćemo uzeti i kada nam trebaju bakterijski probiotici, uglavnom zavisi od toga za šta nam oni, zašto hoćemo da ih koristimo. Jer njihova efikasnost uglavnom, pošto je bazirana na rastu i na kolonizaciji crevnog trakta, zavisi od nekoliko faktora. Od vrste zastupljenih bakterija, od brojnosti zastupljenih bakterija, od različitosti sojeva zastupljenih bakterija i normalno od perioda unosa. Što se tiče samog doziranja, kako i naša crevna biota strogo individualna, tako je i doziranje bakterijskih probiotika isključivo individualno. Druga vrsta probiotskih preparata jesu na bazi gljivica, odnosno kvasaca, i glavni predstavnik njihov jeste Saccharomyces boulardii. Saccharomyces boulardii je otkrio francuski istraživač Henri Boulardi 1923. godine. Radi se o probiotskom kvascu koji ima dokazanu kliničku efikasnost u prevenciji, ali i u lečenju izvesnih simptoma brojnih oboljenja gastrointestinalnog trakta. Jedan takav preparat jeste i flonivin boulardii, koji sadrži, i što ga čini posebnim? Posebnim ga čini njegov sastav. Zašto? Zato što pored Saccharomyces boulardii sadrži i cink i sadrži vitamin D. Pa ćemo u nastavku izlaganja ponaosob da vidimo pozitivne efekte svake od 3 pomenute komponente. Kako deluje Saccharomyces boulardii? Za razliku od bakterijskih probiotika, on ne vrši kolonizaciju crevnog trakta, već veličinom svojih ćelija on direktno vezuje patogene mikroorganizme za sebe, na taj način zaustavlja njihovu kolonizaciju i ubrzava njihovu eliminaciju. Takođe, brojne genomske studije su pokazale veliku održivost Saccharomyces boulardii kroz digestivni trakt, za razliku od bakterijskih probiotika, gde njihovom primenom se zbog prisustva želudačne kiseline, žučnih kiselina, jedan deo sasvim sigurno gubi. Takođe, Saccharomyces boulardii ima značajnu ulogu u stimulaciji našeg imunog sistema, a ima i antimikrobni efekat. Pa da vidimo na koji način to Saccharomyces boulardii ima uticaj i ulogu u našem imunom sistemu. Na prvom mestu, on vrši aktivaciju i sazrevanje antigen prezentujućih ćelija, dendritskih ćelija, B limfocita i T limfocita i makrofaga. Jedan jako bitan faktor u delovanju na naš imunitet jeste takozvani B-glukan, jedna materija koja se nalazi u zidu ćelija svih gljivica, pa i Saccharomyces boulardii. Zašto je on važan? On je važan zato što se ostvaruje veza i stimulacija preko specifičnih receptora, dektrin 1 receptora i to-like receptora koji se nalaze na antigen prezentujućim ćelijama, tako da njihovim vezivanjem sa Saccharomyces boulardii dolazi do te snažne aktivacije celularnog imuniteta i različitih sojeva te ćelija. Kakva je njegova uloga antiinflamatorna? Kad dođe do pojave infekcije, u toj ranoj fazi infekcije, organizam se naš brani tako što intestinalne ćelije crevnog trakta proizvode proinflamatorne citokine, kao neku vrstu odbrane od invazivnih patogena. Međutim, kako ta infekcija napreduje, nivoi proinflamatornih citokina postaju sve veći i veći, tako da oni više ne napadaju samo patogene, već kreću da oštećuju naše zdravo normalno tkivo. Saccharomyces boulardii ima tu sposobnost da suzbija i kontroliše proinflamatorne citokine delovanjem preko antiinflamatornih medijatora, odnosno ima sposobnost da postiže ravnotežu između proinflamatorne i antiinflamatorne reakcije. Najbolje se to možda vidi kroz antiinflamatorno delovanje kod infekcija izazvanih Clostridium difficile, jednom vrlo nezgodnom i opasnom bakterijom, koja svoj patogeni efekat ostvaruje oslobađanjem izvesnih toksina A i B. Ovi toksini i jedan i drugi vrše strašnu stimulaciju proinflamatornih citokina. Kako sad deluje Saccharomyces boulardii? Tako što luči serinsku proteazu koja hidrolizuje ove toksine, drugo inhibira vezivanje ovih toksina za njihov intestinalni glikoproteinski receptor i ono što je možda najvažnije, direktno inhibira rast ove bakterije. Na sličan efekat on ispoljava i svoje antiinflamatorno delovanje na infekcije izazvane Candidom albicans. Druga komponenta u preparatu Fonlivin Bulardi jeste cink. Kao što znamo, cink jeste esencijalni mineral, što znači da ga naš organizam ne stvara, odnosno moramo da ga unosimo isključivo hranom. Hrana bogata cinkom jeste ona životinjskog porekla, mada ima i u hrani biljnog porekla, ali daleko u manjoj količini. Cink obavlja mnogo bitnih i važnih funkcija u našem organizmu. On doprinosi prvo jačanju imuniteta kroz stimulaciju te ćelija, drugo utiče na hormonski balans u našem organizmu, zato je jako bitan u reproduktivnom periodu i muškaraca i žena. Ima izrazit povoljan utisak na stabilnost kože, ubrzava zarastanje rana, ubrzava regeneraciju tkiva, a takođe i u centralnom nervnom sistemu se ponaša kao modulator, odnosno koordiniše rad različitih neurona, tako da na jedan direktan i indirektan način on postiče naš mentalni i fizički razvoj. Šta se dešava ukoliko nam cink nedostaje? Osobe koje su posebno izložene riziku od nedostatka cinka, jer su one osobe koje se isključivo hrane biljnom hranom, znači vegani i vegetarijanci, ali takođe i osobe koje imaju različita hronična oboljenja digestivnog trakta. Takve osobe su daleko izloženije infekcijama zbog slabijeg imuniteta, posebno respiratornim infekcijama, često osjećaju iscrpljenost i umor, a takođe vrlo često pate od izvesnih kožnih oboljenja, a i pokazuju različitu psihološku nestabilnost. Treća komponenta u preparatu Fonlivin Bulardi jeste vitamin D3. Specifičnost ovog vitamina jeste što ga ne nalazimo niti dobijamo iz hrane, nego glavni rezervoar ovog vitamina za ljudski organizam jeste koža koja ga stvara pod uticajem sunčeve svetlosti. I vitamin D3 obavlja brojne bitne funkcije u našem organizmu. Prvo, on održava konstantne koncentracije kalcijuma i fosfata u plazmi. On povećava proizvodnju kalcijum vezujućih proteina u intestinalnim epitelnim ćelijama, a takođe i povećava apsorpciju iz gastrointestinalnog trakta. Pomaže u kontroli deponovanja kalcijuma u kost, ali i u strukture zuba, u dentin i zubne gleđi. Preko kalcijuma na indirektan način, vitamin D3 učestvuje u rastu, deobi diferencijaciji ćelija i direktno ima efekat i uticaj na naš imunni sistem stimulacijom te limfocita. Šta se dešava kada vitamina D3 nema u dovoljnim količinama u našem organizmu? Ako nema vitamina D3, nema ni kalcijuma, odnosno onemogućena je apsorpcija kalcijuma iz digestivnog trakta. Kao posledica toga se javljaju različita oboljenja kod odraslih osteomalacije i osteoporoza, kod dece rahitis. Takođe, vrlo važna stvar kod deficita ovog vitamina jeste što nema aktivacije celularnog imunog sistema, odnosno te limfocita, te ćelije ostaju kao uspavane i zbog toga mogu da nastanu ozbiljni poremećaji u okviru funkcionisanja naše odbrane. Takođe, deficit ovog vitamina povećava rizik od nastanka kardiovaskularnih oboljenja, od nastanka dijabetesa, ali i od nastanka izvesnih karcinoma, prostate, dojke ili debelog creva. Primarna klinička upotreba Saccharomyces boulardii jeste kod zapaljinskih oboljenja crevnog trakta. Bez obzira da li su ona akutne etiologije, kao akutna dijareja, putnička dijareja, dijareja izazvana primjenom antibiotika, ili se radi o hroničnim oboljenjima digestivnog trakta, odnosno ulceroznom kolitu, Crohnovoj bolesti i tako dalje. Sad, kakvu je ulogu našao Saccharomyces boulardii u stomatologiji, odnosno stomatološkoj praksi? Našao je upotrebu u lečenju dentogenih infekcija, odnosno uz primjenu zajedno sa antibiotikom. I sami znamo da su dentogene infekcije najčešće infekcije usne dupe, bez obzira na njihovu patogenetsko poreklo, bilo ono periapikalno ili parodontalno. Lečenje ovih infekcija primarno podrazumeva primjenu hirušku metodu, odnosno hirušku intervenciju, a B, antibiotik samo podrška toj hiruškoj intervenciji, ali nikako alternativa. Generalno gledajući, antibiotici su u stomatologiji propisuju iz dva razloga, profilaktičkih i terapijskih. Međutim, i jedne i druge indikacije su u stomatologiji vrlo uske i ograničene. Međutim, vrlo često u kliničkoj praksi neadekvatnom primenom antibiotika i nesvrsishodnom primenom antibiotika činimo neke druge malo lošije stvari, odnosno to najbolje pokazuje podatak da je učešće stomatologa u generalno u propisivanju antibiotika u medicini zastupljeno sa visokih 10%. Na koji način to mi propisujemo antibiotike, a da je zaista nije opravdano i nije adekvatno? Najbolje pokazuju sledeći primjeri. U Velikoj Britaniji u jednoj studiji došli su do podataka da čak 70% stomatologa propisuje antibiotike kada ne postoji indikacija za to. U Turskoj 21% skoro prepisuje antibiotike samo kod stomatološkog pregleda. U jednoj studiji u Italiji pokazali su i registrovali da je procenat propisivanja i davanja antibiotika gotovo podjednak kod dentogenog apsisa kao i kod pulpitisa, a da pulpitis generalno zahteva samo i isključivo konzervativno lečenje. U Kuvajtu stomatolozi propisuju antibiotike, doduše procenti su niski, ali je bitan razlog i da bi ispunili očekivanja pacijenta za antibiotikom. Zato smo dali jednu, i sad gde su greške, znači tim negativnim propisivanjem, neadekvatnim propisivanjem antibiotika uvodimo sebi iz greške u grešku, tako da počinjemo virusne infekcije da lečimo antibiotikom, lake bakterijske infekcije nakon pozitivnog hiruškog tretmana lečimo antibiotikom, vrlo često nepotrebno profilaktički dajemo antibiotike, izbor antibiotika vrlo često nam biva pogrešan, da u tim početnim fazama razvitka dentogenog apsisa dajemo antibiotike koji ne deluju i nisu potrebni za mikroorganizme koji gotovo i da nema i nisu zastupljeni u tim početnim fazama razvitka dentogenog apsisa, pa sve dotle do subdoziranja, predoziranja, prekratke terapije ili preduge terapije antibiotikom. Zbog toga smo dali izvesne preporuke za primjenu antibiotika u stomatologiji, koje su date u jednom uputstvu za racionalnu upotrebu ovih lekova od strane istraživača sa Oxforda. I kao što možete da primetite, znači ono što se najčešće pojavlja kao prvi lek izbora sa kojim mi možemo dosta dobro da se izborimo i lečimo dentogenu infekciju jesu penicilin V, sinacilin ili u zavisnosti od indikacije sinacilin u kombinaciji sa orvažilom. Svakako, antibiotici nisu selektivni lekovi. Znači, oni pored toga što ubijaju i eliminišu patogene bakterije koje su dovele do dentogene infekcije ili nekih drugih infekcija, oni ubijaju i eliminišu i naše dobre bakterije i na taj način dovode do poremećaja na prvom mestu crevne flore, odnosno dovode do takozvane intestinalne disbioze. Tako se i navodi da gotovo čak 40 do 50% korisnika antibiotika dobije akutni antibiotski kolitis, a čak 20% od njih dobija kolitis izazvan Clostridijom difficile. Normalno, iako se kaže da je infekcija ovom bakterijom Clostridijom difficile uglavnom rezervisana za hospitalno, za bolničko lečenje pacijenta, sve više zbog neadekvatne primjene antibiotika i u stomatologiji se javlja i kod ambulantno lečenih infekcija kao što su i naše dentogene infekcije. Ono što može da se predstavi kao jedan bitan faktor rizika između ostalih jeste i tip antibiotske terapije i dužina antibiotske terapije. Tako da u jednoj američkoj studiji kroz desetogodišnje praćenje došli su do podataka koji ukazuje na porast učestalosti antibiotskog kolitisa izazvanog Clostridijom difficile za čak skoro 240%. Ista studija je infekciju ovom bakterijom, odnosno antibiotski kolitis izazvan Clostridijom difficile svrstala na visoko 9. mesto. Možete da primetite da prvih 8 mesta po uzroku smrtnosti zauzimaju maligniteti gastrointestinalnog trakta. Da se vratimo na antibiotike. Kakve veze imaju antibiotici? U kom smislu su oni taj preveliki faktor rizika za nastajanje antibiotskog kolitisa? Normalno, davanje antibiotika širokog spektra dejstva, predugo davanje antibiotika, često ponovljeno davanje antibiotika i potpuno nepotrebne, nesvrsishodne kombinacije antibiotika. Takođe, veliku važnost i kao faktor rizika ističe se i izbor antibiotika, jer postoje antibiotici koji pokazuju visok rizik od nastanka antibiotskog kolitisa, baš izazvanog Clostridijom difficile bakterijom. To su klindamicin, fluorohinoloni i cefalosporini treće generacije. Ono što je možda važno za stomatologa jeste da je u porastu propisivanje klindamicina, ali takođe i cefalosporina treće generacije, pogotovo kad su pronašli formulu i varijantu za peroralnu upotrebu, odnosno onaj čuveni cefixim. Hempel i saradnici u svojoj metastudiji, odnosno metaanalizi, pokazali su da istovremena primjena Saccharomyces boulardii uz antibiotike dovodi do smanjenog rizika od nastajanja antibiotskog kolitisa čak za 62%. Zbog toga, brojne studije daju preporuke za primjenu Saccharomyces boulardii zajedno sa antibiotskom terapijom u prevenciji nastajanja akutnog antibiotskog kolitisa, kao i u prevenciji nastajanja antibiotskog kolitisa izazvanog Clostridijom difficile. Takođe, Saccharomyces boulardii ima izrazito pozitivan efekat i u eradikaciji Helicobacter pylori infekcije, jer pokazano je da dodatak Saccharomyces boulardii standardnoj trojnoj terapiji kod ove infekcije, znači 2 antibiotika, inhibitori protonske pumpe, značajno povećava stopu eradikacije Helicobacter pylori. Kada bi upoređivali Saccharomyces boulardii i bakterijske probiotike, šta su prednosti, šta su mane? U svakom slučaju velika klinička prednost i efikasnost jeste na strani Saccharomyces boulardii. I to iz više razloga, da ne ponavljam, njihove veličine, ćelije i načina delovanja, veće otpornosti kroz gastrointestinalni trakt, ali na prvo mesto ono što može da bude važno i u stomatologiji i našoj praksi jeste otpornost na antibiotike, te mogu zajedno sa antibioticima da se daju i nemogućnost razvitka rezistencije, odnosno prenos transfera gena odgovornih za rezistenciju na antibiotike, što nije slučaj sa bakterijskim probioticima. I na kraju, kao zaključak i preporuku, možemo slobodno da damo da Flonivin boulardii predstavlja jedan jedinstven preparat, jer u sebi sadrži Saccharomyces boulardii, sadrži cink i vitamin D3, da poboljšava celokupni imunni status našeg organizma, da štiti dobre bakterije i ubrzava oporavak sluzokože crevnog trakta nakon primene antibiotika, što je opet jako važno, ponavljam, može se istovremeno uzimati sa antibiotikom, ima izrazito pozitivno dejstvo na naš imunni sistem i na antibakterijski efekat na brojne patogene bakterije, na adekvatan način reguliše crevnu mikrofloru, ne izaziva alergiju, ne sadrži gluten, ne sadrži laktozu i jako je pogodan kod osoba sa deficitom cinka i deficitom vitamina D3. Hvala vam na pažnji.
Dobar dan kolega.
Dobar dan.
Ja vas vidim, čujem, hvala vam na
I ja vas.
hvala vam lepo. Interesantno imamo jedno pitanje, Sara pita, da li je kod dijareje uvek indikovan probiotik ili postoje li stanja kad se on ne treba davati? Ne razumem, ali dobro. Tu je neka priča medicine koja nije evropska, da probiotici povećaju motilitet creva. Razumete? Pa kao dok je u akutnom stanju, kad je otečeno, da to ne treba davati nego posle i tako dalje. O tome se nešto radi, čini mi se. Baš koliko vidim, pitanje. Da vam predstavim. Znači, da li treba davati uvek kod dijareje ili postoje stanja kod koji kad je dijareja, onda ne treba sad indikovati nego posle ili kako je.
Ajmo ovako, iz početka. Znači ovako, ja sam prvo oralni hirurg. Znači da se ne mešamo previše, da se ne mešamo previše u gastroenterologiju i tako dalje. Ali jeste, upravo tako. Ali u svakom slučaju, kada imate dijareju uzrokovanu opravdanom primjenom antibiotika, znači govorim za dentogene infekcije, ne govorimo o neopravdanoj, nekritičkoj primjeni antibiotika, znači onda zaista da. I u toj situaciji daleko je bolje primjena preparata sa Saccharomyces boulardii nego bakterijskih probiotika. I to iz više razloga. Znači, bakterijski probiotici prvo ih eliminiše želudačna kiselina, tu se gubi jedan deo, drugo, sama primjena sa antibiotikom, tu se gubi jedan opet dobar deo, što nemamo kod preparata Flonidin boulardii koji ima Saccharomyces boulardii.
Dobro. Piše, pozdrav za profesora, sjajno predavanje. Želeo bih malo preciznije u vezi značaja cinka i vitamina D3. Možemo zajedno.
Ajde, da pokušam. Znači, generalno, kad god imamo opravdano primjenu antibiotika, znači ne govorimo o onim situacijama kad mi to prepisujemo nesvrsishodno. Znači, opravdano, imamo dentogenu infekciju, opravdano, indikovano primjenjujemo antibiotik. Antibiotik s jedne strane rešava jedan problem, našu dentogenu infekciju, s druge strane potencijalno može praviti problem gastrointestinalno, remeti flor u crevnom traktu. U toj nekoj situaciji nama generalno, pacijentu, pada imunni status. U toj kombinaciji, jer i Saccharomyces boulardii, i cink, i vitamin D3 podižu naš imunni sistem. Tako da ta kombinacija, ja lično mislim da je dobitna. Ko je god smislio, dobitna je.
Ma jeste, da. Imam kolegu bivšeg studenta koji u Americi živi među Amišima i onda prirodno lečenje, hrana i tako dalje, čovjek se s time bavi. Između Amiša živi, lekar je bio u Teksasu pa se preselio u Virginiju i tamo on vodi rat sa ovim lokalnim i baš on to objašnjava što smo govorili, vitamin D3 dok je bila korona, koliko je važan. Prevara je bila, ako hoćete, nije to lepo ovako govoriti, ali pričam na srpskom pa stranci ne razumu da me neko zavne za uši.
Da.
Bilo Svetske zdravstvene organizacije, jer oni su pravili ispitivanja ne kao prevencija, nego su dali D3 već kad su bili oboleli ili u teškom stanju pacijenti koji su bili od COVID-a, razumete? A predstavili su da su to radili za preventivu, što nije tačno. To je bukvalno bila laž. A on je video, pazite, kaže on, u 3 okruga pozna ih sve, on tamo ih leči kao seoski doktor i šta ja znam što on to tamo radi. Zove se Sklenar, Georg Sklenar. Student moj bio u Novom Sadu. Niko nije umro od COVID-a. Nijedan.
Ako mi dozvolite, izvinite što sam...
Nijedan. Mleko piju, znaš to se. Mislim, to mi ovde kod nas se nije govorilo.
Da.
Piju sveže kravlje mleko. Krave su 80% inficirane COVID-om. Prave imunoglobuline, oni se izlivaju u mleko. I ovi što piju, oni dobiju od krava imunoglobuline, razumete, za virus.
Da, ako mi dozvolite, izvinite
Ako
što
da
vas
ne.
prekidam, znači, rekao bi još neke podatke koje nisu navedene u izlaganju, ali su jako, jako bitne. To je porast infekcije Clostridium difficile kod ambulantno lečenih infekcija, a takve su i naše.
Ja imam loše iskustvo.
Jedno istraživanje u Minnesoti je urađeno, to je jedno 5 puta povećana učestalost infekcije Clostridium difficile kod pacijenata koji apsolutno nemaju nikakve faktore rizika. To su deca i mlade osobe.
Da.
To je strašna stvar.
Ali
Druga
pazite,
stvar,
u Americi se ne pije mleko naročito sveže, obrađeno neko, što mi dobijemo mleko koje se pravi mleko u prahu, nije to sveže kravlje mleko. Da ne kažem šta tamo ima, šta tamo vredi, šta ne vredi, liči na mleko, ali nije mleko koje je sveže dobijeno od krave, razumijete?
Da.
I on smatra, on je baš gledao, on smatra da je najviše bilo zbog toga. A ovo što ste pričali, jako mnogo dece tamo, zabranjuju im da jedu meso, zabranjuju im svašta, potpuno je histerija, jednostavno, ja sam živo 30 godina. I onda je bilo tamo, ja uzmem sladoled da jede, ono petoro mi skače na ruku, da sladoled ima kolesterol.
Imate istraživanja iz Nemačke, iz Velike Britanije, otprilike negde jednogodišnja, zabeležena godišnji slučajevi ove infekcije, baš zbog upotrebe antibiotika na godišnjem nivou 55.000 slučajeva sa smrtnošću od 7%. Pazite, to je i kod nas. To je podatak infektivne klinike Kliničkog centra Srbije. Smrtnost 7% od ove infekcije. To je strašna stvar. Ono što je vezano u stomatologije, a da sad ne idemo dalje, da se ograničimo na stomatologiju, to je jedna strana priče, a to je da kad nama dođe pacijent, koliko mi detaljno, koliko mi uzmemo adekvatnu anamnezu, da pitamo pacijenta kad mu prepisujemo, a vrlo često prepisujemo, nažalost, klindamicin ili još neke druge antibiotike koji su visoko rizični, da li imate problem sa digestivnim traktom. Ali imate i drugu stranu priče, da je pacijent, a to je naš mentalitet. Ja sam došao kod zubara. Mi nismo stomatolozi, mi smo za njih zubari.
Mi smo zubari, naravno.
Upravo tako. Šta ti mene pitaš za moja creva?
Pazite, rat je bio kad je stigao na tržište i kad su krenuli po ordinacijama. Ja sam onda radio na VMC-u, vi me možda i znate, ja sam Lex Svojsler, maksulofacijalni hirurg. I onda su dolazili i delili su klindamicin i ja otvorim i kažem, dobro, šta je indikacija? Onda nije pisalo oralne infekcije, sad piše u ovome. Nego je bilo teške abdominalne infekcije, teške pulmonalne infekcije i tako dalje. To je pisano za klindamicin. Ja kažem, pa što mi to dajete? Pa da pogledamo šta piše. Šta piše unutra uputstvo lekara, gde su indikacije, te oralne infekacije. Ja sam rekao, što to radite? Mislim, a druga stvar, koje su nuspojave. I onda je pisao ulcerozni kolitis i Bog te pita tamo šta. Ja sam protestovao i sad je, ne mislim, pre 2-3 godine su stavili da ima za oralne infekcije. I odmah pucaju. Ja sam preključe dao klindamicin, da vam kažem, baš ima veze s ovim što vi govorite. To mi se desilo 3 puta u životu. Prvi put kod ćerke, drugi put sa ovom pacijentkinjama, radim 40 godina. I sad jedan je sumnjiv na tako nešto. Mnogo mi se, sad ja okrećem se po ordinaciji, nešto nije u redu, nešto, izvor infekcije. Ćerci izvađen zub, neka impaktirani osmica jedna posle 10 dana, ne kaže, znate, mene nešto tu boli. Šta boli posle 10 dana? Ne boli, ja pogledam, vidim onako znoj naduvan obraz i onako slatkat miris gnoja, znači 100% anarob. I dobro, ja dam sve što treba, znači to što ste vi preporučili upravo. I to se sredi. Pre 3 dana dođe posle 3 nedelje, pacijentki je odjedno možda teža ekstrakcija, ali komplikovanija, ako hoćete isto osmice, 3 nedelje posle. Kaže, tu mi je malo tvrdo, obično period za deblje, ja kažem, pa dobro, istrljaj malo tu da će. izgoraš tu krv malo i da se to omekša, ono došlo obrazovki. Bukvalno raste kad ga gledaš. I on se dao klindamicin i orvažio, to je jezivo. I spucao ga je za 24 sata. Ali evo, to je to. Ali za moj život 3 puta. I sad je jedan sumnjiv na tako nešto. Ja sam se već uplašio da se kod mene nešto dešava. U tom segmentu. Ali tako se to desi na kraju kraja, ne treba se brinuti. Ali ja sam ga sam dao klindamicin, zato iz straha, ali ja sam sad u penziji, nemam bolnicu, sad treba nju uvoditi u bolnicu ako krene kako ne treba. Razume da je dajem intravenske injekcije i tako dalje. Ako krene sad flegmonolice i šta znam šta sve možda bude, otko znam. A mlada devojka sve kako treba. Znači, eto, sad sam mu dao, a to se zloupotrebljava, klindamicin se strašno zloupotrebljava.
Jeste, ali vi ste sporadični slučaj, vi ste hirurg, pa ste sporadični slučaj. Problem je u onome što se...
Kolege, nezadovoljni, kaže, juče me boleo zub, tamo, bio sam tamo, nije mi dao ni klindamicin.
Baš tako,
da mi se žali, dolazi mi se da se žali.
Baš tako.
Oni pucaju artiljerijom na muvu, jer pazite, Clostridium je opasna infekcija.
Jeste.
Opalio sam ga klindamicinom i orvažilom. Pa sad, verovatno je bio dovoljno samo klindamicin. Međutim...
Ne, dovoljno je samo orvažil. Orvažil je...
Pa ne znam, ali nisam siguran. Pa i nisam siguran.
Pa ja sam čitao malo...
Imam dete sa ovolikim obrazom na 24 sata, gledam kako raste.
Ali orvažil je izbor terapije kod ovog kolitisa.
Naravno, kad si bio siguran...
Znači, na prvom mestu, kod lakih formi i umereno teških formi, orvažil je lek izbora. Kod onih težih vankomicin...
To znam, posle onda ganjamo one iz rezerve.
To je već ono...
Iz rezerve. Nego relativno sam se uplašio, razumete, gledam ga kako raste obraz, znači flegmona, ja pipam, nema abscesa, nego je to flegmona ko vrata. I tako.
Da.
To je moje neko lično iskustvo koje se desilo s time, ali to sam retko se daje, međutim ja drugi ne. I lepo je ovo predavanje. Samo da pročitam još jedan puta. Molim vas, kažite mi koliko antibiotici u veterinarskoj medicini koji se mogu unositi u hranu u malim ili konstantnim količinama utiču dovode do kolitisa. Zašto veterinarska, ne znam. Kada mi kao doktori još prepišemo antibiotike za stvarne potrebe. Hvala unapred na dobro, divno predavanje. Hvala vas puno. Eto to.
Hvala vama, najlepše pozdrav Novi Sad, pa nadam se da se vidimo i uživo vrlo uskoro.
Samo da čujem evo još jednu, je li imamo vremena još? Ima još. Fino. Kakav je protokol primene probiotika u smislu doziranja kod pacijenata koji su na dugotranoj mikrodozing terapiji antibioticima koje zna potrajati i više meseci? Mikrodozing terapija. Mislim da je iz Hrvatske ili tako nešto. Pa je zbog toga tako napisano.
Mora da mi se definiše tačno šta je to višemesečna terapija.
Pa mislim, ja imam Lyme'sku bolest pa sam pio 2 godine.
Jer pazite, to je nešto vezano ili za bolničko lečenje. Ne verujem da, mislim, moje lično mišljenje, da neko uzima...
Da, nije mi dovoljno jasno da odgovorimo.
Ni meni nije dovoljno jasno.
Mikrodozing je jasno u terapiji antibioticima dugotrajnog. Sad ja nisam mikrodozing, pio sam...
Opet, zbog čega, zašto?
2 godine sam pio.
Ali opet zbog čega, zašto, znači mnogo je toga uključeno u pitanje.
Neko odgovara iz Galenike, na one moje priču, nije preporučen sinergizam, jel da, u davanju klindamicina i metromedazola. Jasna stvar, jedan je bakteriostatik, drugi je baktericid, ja to znam.
Da.
Kad se uplašiš, relativno se uplašiš, jel, jer su ti malo ruke vezane, nemaš bolnicu ispod sebe, ili ja bi nju smestio odmah u bolnicu i dobio je intravenozno te lekove koje treba i gledao bi je, jel? A onaj lokalni pacijent ide kući, mislim, uplaši se. Potpuno jasno, ali radi posao na 24 sata.
Da, odlično radi posao i treba ga samo primenjivati dok traju simptomi, upravo tako.
24 sata, obraz bio ovoliki, sad...
Koliko god, neka traju i 3 dana, ali odlična kombinacija. Ko je smislio, odlična kombinacija.
Jeste, eto to. Ali mislim, treba ga čuvati, to je odličan antibiotik.
Tako je, kao i antibiotike.
Da, treba ga čuvati, mislim, svakako ga treba čuvati, ne za bez veze upotrebljavati. Nemam nikakve pitanja dalje.
Hvala vam najlepše.
Puno hvala kolega.
Hvala vam puno, prijatno.
Mleko je važnije od bilo koji, kaže moj kolega u Pesebrani. Da znate.
Svako dobro, prijatno.
Zahvaljujemo se profesoru Matijeviću, interesantnom predavanju. Sljedeće predavanje u 4 sata. Asistent profesora Nikola Petričević, Croatia. I will tell it in English. He's gonna be presented in English. Assistant Professor Nikola Petričević from Croatia have digital technology over helmet analog dentistry. It's gonna be lecture starts in 16 hours, actually 4 p.m. Until that, I'm send you some nice music.
Nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. No one home. I grieve for you. You to move on. Still loving what's gone. They say life carries on. Carries on and on and on. car that we ride in, the home we reside in, the place that we hide in, the way we are tied in, and life carries on and on and on and on. Life carries on and on and on. Did I dream this belief, or did I believe this dream? Now I can find relief. It was only 1 hour ago. It was all so different then. There's nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. Now there's no one home. I agree. For you, you it's so hard to move on. Still loving what's gone. They say life carries on. Carries on and on and on and on. The news that truly shocks is the empty page, while the final rattle rocks. It's empty cage, and I can't handle this. I'd for you. And you leave me. Let it out and move on. Missing what's gone. They say life carries on. They say life carries on and on and on.
Hello, everybody. My name is Nikola Petricic. I'm professor at the Department of Removable Prosthodontics at the School of Dental Medicine, University of Zagreb. Today, I will talk to you about digital dentistry, or have the digital technologies overwhelmed analog dentistry. In this presentation, I try to collect all the recent data from the longitudinal studies, as well as from the systematic reviews. I didn't rely much on the information provided by the producers of the technology, but I tried to give you, let's say, the most recent and the most reliable scientific evidences. Where are we today? We are somewhere between analog and full digital dentistry, and we are still combining both technologies. But of course, as we can see all around us, we are more and more involved in full digital protocol. What is our goal with digital technology is the same as with analog dentistry, is to achieve perfect, the best white and pink aesthetics. When we talk about analog or conventional procedures, I think everybody is already involved in these procedures and knows well all the protocols, from the first impression to the laboratory phases of waxing, investing, and casting, and to the final office framework adjusting, checking the internal fit, interproximal contacts, and as well as occlusal contacts. In digital procedures, our goal is the same, but in which part did we, let's say, involved, in which part of the dentistry did we reach the peak, and where is still enough space to improve our digital workflow. Everybody knows about CBCT and DCOM data that are already part of our everyday practice. And also thanks to this information, digital navigation implementation is evolving more and more each day. as well as individual bone block production. When we talk about white aesthetics or the prosthodontic workflow, we are interested in quality of our superstructures. And when we talk about quality, we talk about marginal fit, as well as time consuming for the dentist, as well as for the patient and lab staff, about handling materials that can be used in these procedures. Zirconia is now dominant material in this part of the workflow. We can talk about also temporary constructions that serve us to check the aesthetic of our final work. And we also have to talk about survival or the complications of these superstructures and economical background. CAD software and CAM software are today more and more part of our everyday work. The part that was, let's say, is still not missing, but that can be improved a lot is the intraoral scanner. And we also combine this data more and more with extraoral scanners and face scanners. And we are trying to all these layers to put together and to have the final appearance of our patient in all the dimensions. CAM softwares are already well known in our lab procedures and are already an important part of the laboratory workflow. When we talk about scanning, the dentists are mostly concerned about intraoral scanners, their precision and their reliability and easy handling, while the technical part of the work is mostly concerned about CAD or the CAM part of the softwares. That means the cast designing, crown design, framework design, and of course their production by milling or laser ablation or welding or some other methods of production. When we talk about intraoral scanners, from the literature I took out, I tried to present you the best data that are scientifically reliable and that prove that can be, let's say, the base of our today's discussion. I included not only non-powder, but also powder scanners that are, let's say, less in everyday usage, but I still had to mention, let's say, let's say, older generation of scanners, just to give you a comparison of the data and the reliable of this system few years ago and let's say the recent ones, and how this technology developed in just a short time space, in a short period. Personally, I expected that this technology will be developed in the next 10 years, but it seems they are developing much faster and they are more and more becoming part of our everyday work. What does the literature say? What is the cost and the benefit? I divided this information in 4 groups. For single crowns, bridges, so the short span distances, for the semicircular fixed construction, and for the whole arch. When we talk about crowns, I included the information about clinical efficiency, time consuming, not only in office, but also in the lab, marginal or internal accuracy, and what the patients or the dental think about that. Well, are they satisfied or not? When we talk about time consumption, the impression of the tooth, still we can see that with analog technique, we are quite fast, but we are today we are becoming more and more faster with scanners, not only with the ones that use powder for the scanning, but the ones that don't use it. How fast this procedure is with the recent scanner, you can see on this video. So the scanning of one prepared tooth is quite fast. So I think that the new information will show us that the digital technology improved a lot in the last 2 or 3 years. And I'm still waiting for these articles to be published so that I can provide you the most, let's say, the last information, information about time consumption using the scanners without powder. When we talk about time consumption in the lab, from the impression delivery to the lab, to the crown delivery to the office, we can, in comparison with the classical lab production of the crowns, we see from this slide that digital technology improved a lot, and thanks to the softwares, we can design our construction really fast, and we can immediately start producing our final crown. Is it for the patient comfortable? Yes. So the patient think that the scanners are more comfortable than before, or it's the same level as with the classical impression. Is it difficult for the dentist to use scanners? Well, today it is, let's say, still a little bit demanding for the dentist, but the new technique it makes pressure on the dentist to improve or let's say to change their habits and to use the intraoral scanner in a different manner than, of course, with the classical impression with some silicone material. And change in our habits, of course, means improvement in our skills, manual skills, and easy handling with the new scanners. And of course, I think that the satisfaction from the dentist point of view will be better every year. When we talk about marginal fit, of course, this is very important for us. Still, the classical production of the crowns is more accurate, but the new software systems and, for example, CEREC system provides us the same accuracy, but we are talking about centralized system of crown production. Of course, we will see in the next slides how important it is to develop shared site laboratories, not only the centralized in the bigger region, so that the production of our crowns can be faster, but reliable, or even more reliable or more accurate than the classical ones. When we talk about 3-unit bridges, how fast we can scan few teeth to produce the bridge. This video shows us that this scanning goes really fast. This is also the new generation of the scanners. I won't talk about some certain trademarks, but I think that the newest scanners can show us even better data that I'm showing you now right on these slides. But as I said, I'm waiting for the latest publications to give the recent data, and so that I can include it in upgraded lecture, I hope next year. When we talk about timeline, with the scanners, let's say we need a smaller and smaller time period to scan all these teeth than with the classical ones. But when we compare it with the time that we need to design the framework in the lab, well, it takes the time with virtual design from 30 minutes to 40 minutes. So sometimes it can take more time than using the waxing classical procedure. But what before consumed a lot of time for a laboratory team is that they had to design something and to produce these crowns or these bridges in certain dental laboratories that were centralized for a bigger region, for example, in Europe, in few centers. And that took from 3 to 7 days. Today, the new softwares and the new machines or welding or waxing gives us possibility to produce something in a shorter period, and also these distances to be delivered, to deliver some crowns or bridges is shorter. The distances are becoming shorter and shorter. That means that today is something we can design in few minutes and of course produce during the day and deliver that the next day. So this timeline for the for the digital production of the crowns and bridges is becoming shorter and shorter. And of course, these protocols are more simplified than before. And of course, the usage of material is different. That is why we can produce these crowns even faster. So the monolithic structures, zirconia ones, are becoming our daily routine, and they're becoming more and more reliable materials. And of course, their precision is more and more accurate. The marginal fit of bridges in comparison to the classical one is becoming more and more precise, even in those systems that are not using powder anymore. This is, and actually, this made a great gap in the development of digital dentistry, because today the systems don't use a powder anymore, and the new software system and the new precision and easy handling of these scanners, intraoral scanners, opened us a possibility to scan everything so easily and smoothly, and to have the precision of our final models, sometimes even better than we can, let's say, register these small details with the classical impression. When we talk about single crowns, the recent articles show us that digital technology can sometimes even provide us better marginal details than the conventional impressions. When we talk about short span bridges, there is no big difference, no significant difference. And also zirconia restoration showed smaller marginal discrepancy versus conventional ones. When we talk about in vivo studies, there is no significant difference, but in vitro studies, still, few years ago, the digital impression resulted even in better marginal adaptation, because in controlled situation, we can really use the maximum of our softwares and scanners. But in vivo, doing that on the patient, let's say that both the classical impression and the digital one are, let's say, more or less equal. So what can we, let's say, in a short sentences conclude about short span bridges? Well, that this technique is more accurate and more efficient when we compare it to the classical ones, but of course in perfect conditions. What is about marginal fit or the accuracy in those bridges? Well, it's similar, and same results we have between digital and conventional impressions concerning the fabrication technique. But when we talk about material, I have to underline then metal alloy reconstructions show the smallest marginal discrepancy compared with glass, ceramic, and zirconia restorations. Why this precision marginal fit is becoming better and better every day in dental lab using the digital technology? It's because we can see the smallest details. Sometimes under the control of eye, we can see sometimes the smallest details, but on our screens, using the digital technology, our image can be bigger. We can, let's say, zoom some small details, and we can be really precise. When we talk about complete fixed partial dentures, time consumption with scanner is now much bigger. We need to scan some spaces, some surfaces more times to have more images, and this takes time. And also the post-production with all these photos is sometimes demanding for the softwares, and it takes a longer period in comparison to the classical impression of more teeth of the whole dental arch. Is it comfort for the patient? Yes. So it's let's say it's comfort with the classical impression, but also with the scanner. But of course, with some scanners that are using powder, patients think that it's not comfortable, of course. Is this impression difficult for the dentist? Well, the classical one is not so demanding for the dentist. Why? Because he's used to do it every day. But the handling of the big, let's say, bigger scanners, and also trying to scan the bigger distances, let's say the whole arch, it's the dentist think that it is quite demanding for him. So I think during the years when we, let's say, catch all the details, when we improve our handling and our manual skills, it will be easier and easier for the dentist to scan not only one tooth, but also the whole dental arch. If we talk only about dental arch, and if you compare the classical impression with the systems that use powder, well, the working in mouth takes much more time with the scanners, but the production is much shorter, the design period, while with the classical one, the production in the lab sometimes takes a longer period of time. Yeah, and of course we have to mention that we calculated also the time for the classical impression, the time that needs for our delivery system, for our transportation, because sometimes it takes not only 1 hour, it takes the whole day until our impression reaches the lab, until they pour the model, and until they design the final superstructure. If we talk about impression comfort, patients think that classical impression is still easier to sustain in comparison to the scanners and the scanners, of course, that use powder. If we compare all this data between classical impression and the scanners that don't use powder, then the patients have a different opinion. For them, it's comfortable to wait until we scan all the teeth or the dental arch using the scanners without powder. So elimination of the powder in our scanning process allowed us, let's say, it improved the situation for the patients a lot. And the accuracy, of course, it's accurate with the classical because we all know the procedures, we know the mistakes that we can do, we don't repeat our mistakes. While in the scanning system, I think still is the problem how to handle all this process. It's easier with, of course, with the younger technician, as we know. For them, it's natural to use digital technology, but for older generations, sometimes it's very hard to apply the new technologies, and still we don't have so, let's say, the same precision as with classical impressions. It's not only, it's about, of course, about softwares, about scanners, but of course, it's also about education of dental staff and the dentist as well. In summary, what we can conclude, well, what would be our literature review or the final tips and tricks? So we know that further improvement in accuracy is expected in the future, development of scanner systems and softwares. And of course, we need new, more high quality trials so that that we can, let's say, have the most recent information about development of different digital systems and softwares. We need new trials because it seems that the science is slower than the industrial progress of available digital applications. What we can conclude at the end, is it reliable for us as a practitioners to use dental scanners? Of course. We can say it's 100% reliable for diagnostic purposes and short span scanning. But for bigger spans and for the whole arch or semicircular bridges, we need more data, how accurate the digital technology is, how precise it is, and what are, let's say, the mistakes that this system makes and how we can improve it. But of course, it is the time for us to get involved in digital technology because we will have to accept it. It's not our future. It's already here. Thank you very much for your attention. It was for me a great opportunity, and I'm very grateful to have this opportunity to give you this lecture on this wonderful congress. Thank you very much. Bye bye.
Thank you very much. We should talk in English because we have a foreigner, subscribers. Nicola, if somebody call us, there are some questions in Serbian, so I'll tell you. But anyway, we should better talk in English. Hello.
Hello.
Yes, you can hear me. I hope so. Thank you for the nice presentation and technical support for us. This is, of course, you're working in the institute, right? And this is technical support is by the institute or the university is always better. This question is very interesting for you and for us who are now private doctors. I have some private studios and private surgery. Some of these Dr. Stefan ask you, which scanner do you use and prefer and why? It means if you're going to work now privately, that you have all funds to organize the studio, to buy everything, what kind of scanner? So if you are supported by the government, of course that you will probably have the opportunity to have the best one, the latest one, and this is the best, of course, you show to us. But if you have to, first question is, if you have to start your own with some restricted funds or something like that, what scanner you will buy?
Well, actually, I have to admit that I tried few of them. So when the time came to present me, when the distributor had the opportunity to get one scanner, of course, I tried it and I tried many of them. But actually, to be honest, the one which I'm working in a practice is 3Shape. So I'm not sponsored by 3Shape, but I just like because it's easy handling. And I have to admit that now I'm trying the new one. I don't want to talk about new scanner because first I want to see is it reliable, how precise it is, and then I will implement it in my next presentation. So let's say this presentation also already needs to be, let's say, a little bit refreshed. Why? Because it's done 6 months ago. So already these 6 months, I have new data to provide you in my next presentation, maybe for the next year. So let's say maybe in the 6 months, we will talk about some new data and how reliable scanners are. So my opinion that now after 6 months, I have new data and that really I can confirm from the scientific level that the scanner is also reliable for a full arch. Yeah, but I have to, but that is something for the next lecture.
No, it's okay. That the point is for the others, if you are supported by the government, you have funds who are large, of course, and some kind of C-RONA technology. It is approachable, something like that. Of course, that you will have a position to try all of this and to work with this because you are at university. But if you are private, I have to think about the funds. So the question was, if I want to buy it now, I don't have enough money or system to buy the latest one, the biggest one, or newest one, because you are very experienced in that. So that was the question for you. Which one would you will buy?
Well,
In this moment, this one, but maybe in 6 months, something else. Who knows?
I know. Okay. The old problem of the scanning was this accuracy, the intermediate part of the teeth, as you've been talking. This one between the teeth and this one to try to, okay, this is the old problem. But generally, I was working with some scanner, and there was not a big problem actually like this, because this non-accuracy could be because of non-parallel preparing the teeth. Because you have machine who is excellent, and my hand is not machine, right?
Yeah,
sometimes sometimes is this non-accuracy because he cannot correct, scanner cannot correct something on the teeth which is not parallel, ideally parallel, right? And my hand is not robotic arm, right? I'm doing try my best, but I'm man, this is machine. So generally the latest 3-shaper, probably this one, new one you are testing, I think its accuracy is completely good. Generally, I think they did it generally like this. So you will not have this preserving papilla and blah blah blah, all of these things. I think it's generally satisfactory. So
yeah,
I'm happy that we have somebody who is in the position to do with all of these things and give us some impression, because I cannot, if I am private, I buy one machine for the next 5 years, 6 years, I can only change the software, but I cannot buy a new machine probably, something like that.
I understand you completely, because also working in a private practice, for me, I had to choose one. Yeah, in that moment, which one to pick up and which one, let's say, to use for a certain period of time, not just for a few months. Yeah, it's too expensive.
Years, at least. A business plan is always in 5 years, something like that. So you have to, to buy something and to do it in 5 years, and so like this in a practice.
Yeah, but what really surprised me in this digital revolution is that it's really going so fast and even faster. So, for example, I mentioned in my presentation that something will happen in 10 years and maybe sooner. But now I can really say that after 1 year, it already happened what I expected to happen in 3 years, to be honest. So it's really changing.
What is the problem? This is a huge amount of money, so we can take some leasing, some on a credit or something like that. And next year you will have something better.
Yes.
Probably something better.
Yeah.
So this is actually problem. Actually, this is a problem, but.
Yeah, that is let's say the point of presentation, just to show that we have to accept it as this digital revolution, and that we have to be involved in it because it's here already. So it's something that is becoming more and more part of our daily life in office. So let's do it. Let's try it.
Of course. Thank you very much. There is no.
Thank you very much.
Question. It was nice, presentation. Good for us to see your impression, because you are working on this machine, and this is good, your experience for us. Thank you very much, Nicola.
Thank you very much for the invitation. Thank you.
Thank you. Bye.
Bye.
I'm calling now Siniša Mirković, professor from Novi Sad, from Serbia, odontogenic infection. It's going to start in about 17 hours. It is 5 p.m. And until that time, we will put some music for you. Some suitable music.
Nothing yet has really sunk in. Looks like it always did. This flesh what's gone. They say life carries on. Carries on and on and on and on. The news that truly shocks is the empty, empty page, while the final rattle rocks. It's empty, empty cage. And I can't handle this. I grieve for you. And you let it out and move on. Missing what's gone. They say life carries on. They say life carries on and on. And on. Life carries on in the people I meet, in everyone that's out on the street, in all the dogs and cats, in the flies and rats, in the rot and the rust, in the ashes and the dust. Life carries on and on and on and on. Life carries on and on and on. It's just the car that we ride in, the home we reside in, the face that we hide in, the way we are tied in. And life carries on and on and on and on. Life carries on and on and on. Did I dream this belief, or did I believe this dream? Now I can find relief. I grieve. was all so different then. There's nothing yet has really sunk in. Looks like it always did. This flesh and bone is just the way that you were tied in. Now there's no one home. I agree. For you, you it's so hard to move on. Still loving what's gone. They say life carries on. Carries on and on and on and on. The news that truly shocks is the empty, empty page, while the final rattle rocks. It's empty, empty cage. And I can't handle this. I'd read
Poštovane koleginice i kolege, dobar dan. Izuzetno mi je zadovoljstvo i čast što imam priliku da na ovom našem stručnom skupu podelim sa vama neka od svojih ranijih iskustava. Moje ime je Siniša Mirković, za one koji me ne znaju, dolazim iz Novog Sada, radim na medicinskom fakultetu, odnosno na klinici za stomatologiju Vojvodine i šef sam službe za oralnu hirurgiju i implantologiju. Nakon razgovora sa organizatorima došli smo do zajedničkog zaključka, s obzirom da sam dobio ono što se kaže carte blanche, priliku da odaberem predavanje koje ću vam održati. Smatrao sam da je najsvrsishodnije, s obzirom na iskustvo koje imam u radu u tercijarnoj zdravstvenoj ustanovi, da pričam o dentogenim infekcijama. Ovo je malo prilagođena tema, s obzirom da je u pitanju ipak implantološki skup, odnosno da je akcenat više bačen na implantologiju, međutim, naravno da i implantati koji ugradimo predstavljaju celinu dentoalveolarne regije nakon njihove integracije, tako da i oni, po znacima navode, mogu biti uzroci dentogenih infekcija. Ovo je jedan slajd koji pokazuje da dolazim iz Novog Sada i sa klinike za stomatologiju Vojvodine. No, da krenemo, infekcija predstavlja uspešan prodor patogenih mikroorganizama u tkivo domaćina. Znači, pravimo jedan opšti uvod, a dentogeni ili odontigene infekcije nazivaju se procesi koji poreklo vode od oboljenja zuba, a u slučaju implantoloških komplikacija vode poreklo od nekih neželjenih stvari koje se javljaju oko implantata koje ugradimo. Ono što treba da znamo i da naznačimo koji su faktori koji utiču na razvoj i širenje dentogenih infekcija. A to je kao prvo opšte zdravstveno stanje naših pacijenata, zatim broj vrsta i virulentnost mikroorganizama, kao i anatomski faktori, a to su prevashodno zub, zatim ugrađen implant, kost, periost, suzokoža, zatim pripoj mišića, krvni i limfni sudovi, kao i koža. Što se tiče podele dentogenih infekcija, prema kliničkom toku možemo ih podeliti na akutne i hronične, a prema lokalizaciji možemo ih podeliti na periapikalne, parodontalne, perikoronarne i u slučaju implantata periimplantne infekcije. Isto u odnosu na kliničku sliku imamo opet jednu podelu, odnosno tipova dentogenih infekcija, a to su apseks, flegmona i celulit, kao što možete videti na prikazanim slajdovima. Takođe, izuzetno značajno porazgovarati o fazama razvoja dentogenih infekcija. Prva i osnovna je periodoncionska, znači koja se nalazi neposredno u okolnom tkivu oko korena zuba. Zatim, daljim širenjem infekcije nastupa intraosealna faza. U slučaju postavljenog implantata, to je takođe intraosealna, s obzirom da je implantat endoosealni. Zatim, daljim širenjem infekcije dolazi do pojave subperiostalne faze, gde infekcija probija kost i dolazi do lokalizacije ispod periosta. Treba naglasiti da je ovo izuzetno bolna faza razvoja infekcije, s obzirom da je periost izuzetno dobro inervisan i u daljim nelečenim slučajima, u zavisnosti od pripoja mišića, razlikujemo submukoznu ili subkutanu fazu širenja infekcije. Takođe, značajni su i klinički znaci dentogenih infekcija, a delimo ih na opšte i lokalne. Opšti su malaksalost, temperatura, pad opšteg zdravstvenog stanja organizma, zatim promene u laboratorijskim nalazima kao što je leukocitoza, povećan CRP, skretanje leukocitarne formule u levo, ubrzana sedimentacija eritrocita, dok lokalni znaci koji su daleko značajniji za nas, to su kalor, rubor, tumor, dolor i funkcio leza, odnosno povećana lokalna temperatura, crvenilo, otok, bol, kao i poremećena funkcija. Što se tiče dijagnoze dentogenih infekcija, kao i svuda, i ovo je klasičan slajd, a to su anamneza, klinički pregled, rengenografske metode, kao i laboratorijske metode. Što se tiče implantologije, uglavnom kontrolni RTG, da li klasični ortopantomografski snimak ili retroalveolarni snimak, u krajnju ruku i 3D CBCT snimak, nam mogu dati značajne informacije u pogledu stanja tkiva oko našeg ugrađenog implantata. Što se tiče terapije dentogenih infekcija, generalno možemo podeliti na konzervativnu i hirušku. Konzervativna je kauzalna ili simptomatska, dok hiruška može biti incizija, drenaža, ekstrakcija zuba ili u slučaju implantata, eksplantacija ugrađenog implantata. Sada, najznačajniji tip infekcije jeste absces, koji predstavlja lokalizovanu gnojnu kolekciju mekih tkiva dentoalveolarne regije, i to mekih tkiva lica, vilica i vrata. Abscesi koji su lokalizovani u predelu gornje vilice, u zavisnosti od regiona, razlikujemo absces forniksa ili vestibuloma gornje vilice, zatim absces tvrdoga nepca, zatim razlikujemo retromaksilarni absces, absces obraza i absces očinjačke jame. Što se tiče abscesa lokalizovanog u predelu donje vilice, razlikujemo perimandibularni absces, zatim submandibularni absces, zatim submentalni absces, absces brade, sublingvalni absces, kao i pterigomandibularni absces. Sad ćemo malo pričati o kazuistici i gde će biti prikazani putevi širenja infekcije i na koji način gnojna kolekcija stiže do određene regije. Usput, u gornjem delu slajda su i dijagnoze napisane na latinskom, tako da imamo absces forniksa maksile ili abscesus fornicis maxile dentogenes. Kao što vidite, u bočnoj regiji zavisi od pripoja muskulusa buccinator. Tako da u forniksu infekcija će se u gornjoj vilici pojaviti u forniksu ukoliko gnojna kolekcija probije kost ispod gornjeg pripoja muskulusa buccinatora. Kao što vidite, vidimo lokalizovani otok, da su zaokružene uglavnom jarko-crvene boje. Terapija je naravno incizija i drenaža, znači pažljivo u lokalnoj anesteziji, koja može biti ili sprovodna, ili submukozna, ili površinska. Pažljivo presecamo tupom stranom, znači ispupčenom stranom noža, samo mukozu, tupim instrumentom peanom ulazimo u abscesnu šupljinu, praznimo abscesnu šupljinu i nakon toga postavljamo gumeni dren, koji je najbolje fiksirati pojedinačnim šavom da ne bi došlo do njegovog ispadanja. I naravno, kontrole se prave na 2 do 3 dana uz obaveznu antibiotsku zaštitu, da bi videli da li još ima supuraciju iz incizione rane i ono pravilo koliko stoji dren. Dren stoji u incizionoj rani dokle ima sekreta. Onog momenta kad vidimo da više nema ništa, da po znacima navoda curi iz incizione rane, dren se vadi napolje i ostavljamo dalje rana da zarasta, a mi se onda bavimo uzrokom same infekcije. Zatim imamo abscesus palati duri maksile, znači absces tvrdoga nepca, u najvećem broju slučaja vodi poreklo od lateralnog cikutića ili palatinalnih korenova gornjih bočnih zuba. Ukoliko imamo palatinalni absces od lateralnog sekutića, kao što vidite na prikazanim slajdovima, ne radi se samo incizija, nekad je preporučljivo uraditi i malu eksciziju da ne bi došlo do zatvaranja incizione rane. Opet se ulazi peanom, drenaža se uradi, postavlja se dren i kao po prethodno opisanoj proceduri se vrše protokoli. Mora se voditi računa da pravac incizije ide paralelno sa pravcem pružanja arterije palatine major, da ne bi došlo do njenog presecanja. Kao što vidite na prikazanim slajdovima, znači u lokalnoj anesteziji uradi se ekscizija jednog dela suzokože, nakon toga se otvori peanom apcesom šupljina, evakuiše se patološki sadržaj i postavi gumeni dren i može se fiksirati pojedinačnim šarom. Što se tiče apcesa lokalizovani u donjoj vilici, mišići koji utiču na pravac širenja infekcije jeste milohioidni mišić sa lingualne strane, kao i musculus buccinator sa vestibularne strane. U forniksu infekcija nastaje ukoliko gnojna kolekcija probije kost iznad pripoja muskulusa buccinatora. Znači, u tom slučaju kolekcija biva formirana i lokalizovana u predelu forniksa, odnosno u mekim tkivima sa vestibularne strane alveolarnog grebena. U ovom slučaju može se dati sprovodna anestezija, uradi incizija, opet otvori peanom gnojna kolekcija, postavi gumeni dren i uradi evakuacija patološkog sadržaja. Nakon toga imamo apces regija buke ili apces obraza. U ovom slučaju apces obraza može da nastane od patološkog procesa i gornjih i donjih zuba i ovde je glavni faktor širenja infekcije pripoj muskulusa buccinatora. U donjoj vilici, ukoliko gnojna kolekcija probije kost ispod pripoja muskulusa buccinatora, ide u obraznu regiju, a u gornjoj vilici, ukoliko gnojna kolekcija probije kost iznad pripoja muskulusa buccinatora, infekcija se širi u obraz, kao što možete vidjeti na prikazanim slajdovima. U tom slučaju radi se ekstraoralna incizija. Kod ekstraoralne incizije je izuzetno važno koliko je moguće obrijati pacijenta, kožu prvo predrisati benzinom da bi se odmastila, zatim nekih od dezinfekcionih sredstava. U lokalnoj anesteziji, u najvećem broju slučajeva je to subkutana anestezija, može biti i površinska ili hlađenje metilkloridom. Pažljivo se preseče samo koža, vodeći računa o važnim anatomskim strukturama kao što je arterija facialis, znači samo se proseče koža. Tupim instrumentom se ulazi u gnojnu kolekciju, evakuiše se patološki sadržaj, postavlja se gumeni dren i nakon toga se obavezno vrši previjanje rane. Kontrole se rade na 2 do 3 dana gde se vrši promena drena i naravno previjanje same rane. Ovo je sada prikazan apces submandibularne regije ili ti abscesus regius submandibularis tentogenes. Ovde je važno napomenuti da je gnojna kolekcija probila kost sa lingualne strane ispod pripoja muskulusa milohioideus. Kao što vidite na slajdovima dominira otok ispod donje ivice mandibule. Ovde moramo voditi računa o anatomskim regijama i moramo voditi računa o mestu gde vršimo inciziju. Incizija se po pravilu vrši 2 prsta ispred angulusa mandibule i 2 prsta ispod donje ivice mandibule. Isto tako bi bilo zgodno ubrijati pacijenta, dati ili subkutanu ili površinsku anesteziju ili hlađenje. U ovom slučaju nekad možemo dati anesteziju i za punktum nervozum coli, gde u velikom broju slučajeva dobijamo anesteziju i ovog područja preko nervusa transversusa coli. Isto tako pažljivo presecamo samo kožu, tupom preparacijom dolazimo do apcesa i šupljine, probijemo je peanom, evakuišemo sadržaj, postavimo gumeni dren i obavezno nakon toga radimo previjanje rane i kontrole na 2 do 3 dana za menjanje drena i previjanje rane i čišćenje operativnog područja. Zatim imamo submentalni apces ili abscesus regius submentalis tentogenes. U ovom slučaju dominira fenomen duple brade. Kao što vidite na slajdu, dominira crvena, otečena, lividna koža, palpatorno izuzetno osetljiva. Ovde je gnojna kolekcija probila kost ispod pripoja genioglosnog i geniohidnog mišića i prednjeg trbuha bigastrikusa i biva lokalizovana ispod donje ivice brade. Kao i u prethodno dva slučaja, moramo obraditi prvo kožu, znači dezinfikovati, prebrisati benzinom, alkoholom ili nekim od dezinfekcionih sredstava. Nakon toga vršimo polukružnu inciziju paralelno sa donjim ivicom brade da bi ožiljak bio što manje uočljiv. Tupim instrumentom opet ulazimo u apcesnu šupinu, vršimo evakuaciju gnojnog sadržaja, postavljamo gumeni dren i nakon toga naravno radimo prevoj operativnog ili zavijanje operativnog područja. Zatim imamo sublingvalni apces ili abscesus regius sublingualis dentogenes. Kao što vidite na slajdu, otok dominira na podu usta, izdignute, palpatorno osetljiv, jezik je pomeren u zdravu stranu i infekcija je probila kost sa lingvalne strane iznad pripoja muskulusa milohioideus. Terapija je takođe incizija i drenaža, međutim ovde moramo voditi računa o pravcu pružanja incizije, znači rez mora ići paralelno sa alveolarnim grebenom da bi se izbeglo presecanje izvodnih kanala sublingualne i submandibularne pljuvačne žljezde, kao i velikih krvnih sudova koji se nalaze na podu usne dutlje. Isto ulazi se panom, vrši se evakuacija gnojnog sadržaja i postavlja se gumeni dren. I na kraju, u krajnjem stadijumu imamo parodontitis apicalis chronica cum fistula extraoralis dentogenes. Znači, gnojna kolekcija je probila sve moguće strukture i pojavila se na koži sa formiranjem ekstraoralne fistule. U ovom slučaju, ovo spada u grupu sad hroničnih procesa. Fistula neće biti zatvorena s obzirom da je obružena epitelom, mora se ukloniti fistulozni kanal u potpunosti. Kao što vidite, uzročnik je zaostali koren sa leve strane donjega molara. Ekstraoralni je pristup, napravi se elipsasta ekscizija dela nekrotične kože. Nakon toga se neizmeničnom tupom oštrom preparacijom potpuno isprepariše fistulozni kanal do kosti. U istom aktu se bio izvadio i koren, iskiritirao granulaciono tkivo koje se nalazilo u kosti. Na donjem desnom slajdu vidite isprepariran u potpunosti fistulozni kanal i nakon toga se rana šije po slojevima, znači ušiva se mišićni sloj resortivni koncept i nakon toga obično najlonom ili nekim drugim sintetskim monofilamentnim šavnim materijalom se ušiva koža i obavezno ide previjanje operativne regije, kontrole na drugi, treći dan, dezinfekcija operativnog područja, zamena zavoja i negde 8. do 10. dana se vrši uklanjanje konaca. Zaključak čitave ove priče bi bilo da dentogenne infekcije zapravo predstavljaju česte patološke procese dentoalveolarne regije, u čijem lečenju značajno mesto ima naravno prevencija, koja podrazumeva redovne kontrolne preglede od strane nadležnih stomatologa, naravno kao i rana sanacija karioznih lezija. Ja vam se ovom prilikom zahvaljujem na pažnji. Izvinjavam se eventualno na greškama u toku izlaganja. Svi znaju da sam ja čovek koji ne voli online predavanja i da volim uživo da se vidim sa auditorijom i kolegama kojim predajem, ali sticajem okolnosti, ovaj naš skup odlučeno je da ipak bude održan online. Ja vas ovim putem pozdravljam. Prijatno i doviđenja i hvala na pažnji.
Pa da ne bude online, drago mi je što vas vidim, poštovani kolega. Pa, ovaj put je moralo da bude online, sledeći put nisu ovo, ako možemo da pričamo. Da vidim šta ima neka pitanja za vas. Da, pogledam ima šta.
Bilo je jedno pitanje koliko sam video.
A da li se po protokolu pacijent suspektan na flegmonu, verovatno baze usta misli, hospitalizuje ili
Prvo želim da pozdravim mog prijatelja, kolegu Vojislava, želim da pozdravim mog kolegu Zombu Marjanovića, da im se zahvalim na enormnom trudu i radu, treba ovo sve organizovati, naravno, i da to sve funkcioniše, pogotovo u online varijanti. Želim da pozdravim i sve učesnike, da li se ovo sad stručno zove webinar ili kako god online mitinga, i što je ove godine uspešno organizovan sastanak USSI EDI organizacije i ponosan sam što sam deo toga. Još jednom se izvinjavam na greškama, jer kažem, ja volim da vidim i moje kolege, i predavače, i auditorijum, i moderatore i tako dalje, no nadam se da mi kolege neće uzeti za zlo. No da ne dužim, što se tiče pacijenata sa flegmonom poda usta ili flegmona bazeosoris ili angina ludovici, prvo zavisnosti od opšteg zdravstvenog stanja, odnosno kliničke slike pacijenta, naravno u kakvom stanju vam dođe. Drugo, koliko ste izedukovani za to, da li je došao takav slučaj u privatnu praksu, da li je došao slučaj u tercijarnu zdravstvenu ustanovu, u ovom slučaju recimo odeljenja oralne hirurgije. Ja koji već spadam recimo u grupu starijih oralnih hirurga, lečio sam flegmone bez hospitalizacije. Međutim, s obzirom na onako agresivnost samog patološkog procesa i dobrobit pacijenta, ja sam ipak možda za to bez ikakve sujete postati pacijenta maksilofacijalnom hirurgu. Ipak postoji mogućnost hospitalizacije, monitoringa pacijenta, parenteralne primjene antibiotika koja je mnogo efikasnija nego peroralna, s obzirom da su se malo i protokoli davanja parenteralne terapije promenuli, da to mora da bude u domovima zdravlja ili u odgovarajućim zdravstvenim ustanovama. Takođe, zavisi i od opsežnosti incizija koje jesu osnova terapije flegmone, da li to VY incizije i tako dalje ili više manjih. Znači, moj savjet lekarima i mlađim, a i starijima koji nemaju iskustva, da ipak ne treba biti sujetan, poslati pacijenta specijalisti za maksilofacijalnu hirurgiju koji će proceniti da li će odraditi hospitalizaciju pacijenta uz adekvatan monitoring i adekvatnu parenteralnu terapiju ili će nešto uraditi u lokalu, ali uz kontrole redovne opet u ustanovi tercijarne zdravstvene zaštite, s obzirom da svi se mi plašimo glavne komplikacije flegmone poda usta, to je u ovom slučaju mediastinitis, koji i dalje, s obzirom na sve moguće terapije kojima raspolažemo, i dalje se karakteriše visokim stepenom smrti. Eto, to bi bilo neko moje iskustvo.
Hvala kolega, tačno je to. Jednom rečju, obično iskustvo je to kad imate submentalni početak pa je tvrdo i tako dalje. U submentalnom delu lako možete da date lokalnu anesteziju, to je samo jedan vertikalan rez po srednjoj liniji, može da se otvori. Kad je to manje, to je ipak lokalizovano ispod brade. Kad počne sa leve i desne strane da se širi na vrat, onda je potrebna opšta anestezija. Nebitno je da ćete to vi uraditi ili maksilofacijalni ili bilo ko. Potreba vam je, u stvari, treba vam je hospitalizacija, treba vam opšta anestezija, monitoring tog pacijenta i o tome se radi. A incizija je svakako važna. U toj situaciji, otprilike po mom iskustvu, to je to ispod brade, još možda se zaustavi ako može, brzo, da ne krene dalje, to znači na kontrolu. To bi moglo da se u lokalu uradi i ne mora tako radikalna rez da se odmah napravi. A ako ne treba kako treba, onda mora već kako mora, a to je već spasavanje života i onda ste rekli, to je to. Ne vidim ništa. Neko pitanje drugo. Ja se zahvaljujem kolegi puno na jednom dobrom predavanju, da mi osvežimo naše znanje, je bilo stvarno dobro, lepo objašnjeno.
Onako, malo edukativno karaktera.
Hvala, to je treba svakako i to je dobro. Puno se zahvaljujem i ovo je kongresa, sutra nastavljamo. I have to announce this is for today. It was the first day of the Congress. Thank you all participant professors, lecturers, anybody who presented today, all of these things. Thank you, the crew here, who helped us here with the technical support. And thank you, everybody. I call everybody tomorrow at 10 o'clock. We proceed from good lectures. We will have from England, from France, from Portugal. I hope it's going to be interesting for you. We're going to try to do the best of ourselves to make you this interesting and useful for all of us. So goodbye until tomorrow, 10 o'clock a.m.
The things that we've been through, you should understand me like I understand you. Now girl, I know the difference between right and wrong. I ain't gonna do nothing to break up our happy home. So don't get excited when I come home late at night, 'cause we only act like children when we argue, fuss and fight. If you don't know me by now, if you don't know me, you'll never, ever, ever know me. No, you won't. No, you won't. We've all got our funny moods. Honey, I got mine. Woman, you got yours too. Just trust in me like I trust in you. And as long as we've been together, that should be easy to do. So just get yourself together, or we might as well say goodbye. 'Cause what good is a love affair? What good